Active Health Connecticut. We are joined today on my right by representatives from Anthem, Cigna, and Connecticut. And what I will do is provide some context here. The weighted average requested rate increase in the individual market for all healthcare is 12.4%. Medicare benefits is requesting a 12.7% increase. Connecticut Insurance Company is requesting a 17.5% increase. Connecticut Inc., which is an HMO, is requesting an increase of 15.4%, and Anthem requests an increase of 9.8%. Now, the weighted average requested rate increase in the small group market for all health insurance carriers is 14.8%. There are only two insurers in that market. Cigna is asking for an increase of 23%, and Anthem is requesting an increase of 14.9%. And the small group market, by the way, is defined as employers with 50 or fewer employees. If you have not yet seen them, copies of all the filings for all the carriers, so that's Aetna, CVS, Anthem, Cigna, Connecticut, and United Healthcare Oxford, and all related documents have been posted on the CID website for public review and comment since July 8th. Now, the proposed weighted average individual rate increase request is 12.4%. That compares to 20.4% in 2023, ranges from 9.8% to 17.5%. For the small group, the average is 14.8%, which compares to 14.8% again in 2023, and it ranges, depending on the particular group, from 7.5% to 23%. These health plans that we will discuss today, the health plans over which the state insurance department has authority, covers approximately 190,000 Connecticut residents, or 5% of the total 3.6 million population of the state. If you receive health coverage from Medicare, Medicaid, through a union, through the state, or a municipality, these filings do not affect you. Most Connecticut residents are covered by plans offered by their employer, and those plans are regulated, the self-insured plans are regulated by the U.S. Department of Labor. The state insurance department does not regulate those plans, and they are not subject to this review. In addition, the filings under review today are not standalone. I just want to make it clear to everyone in attendance and watching the full scope of what is on review and what we have authority over. Now, the positive news I would share on that, if anyone has health coverage from one of those plans I just mentioned, and if you have issues, concerns, or just questions, the Office of Healthcare Advocate has a dedicated staff that has been created by the state to assist you. And the director of that Office of Healthcare Advocate, who will be here today, who will be asking questions. But that office, you can always reach out to the plan for the state insurance department has no authority. Now, the filings we are discussing here today are currently under an actuarial review. We've got a bunch of actuaries who will be asking questions to ensure our perspective. And by September, we can decide whether to approve, reject, and modify all of those. And this timeline is primarily determined by the Affordable Care and the need that we have to ensure that active health has rates in time to comply with the requirements of the Affordable Care Act. So people who are making choices during the will be able to do that. We've got some key members of the Connecticut Insurance Department staff here today, like introducing children. To my left, to my immediate left is Paul Johnson, who is the Assistant Deputy Commissioner and Director of the Licensed Health Division. To his left is Wanton Chu, who is Assistant Deputy Commissioner, Chief Actuary, and Head of the Data Sciences Division. To Wanton's left is Richard Day, Chief Licensed Health Actuary. On my immediate right, Deputy Commissioner Jared Koski, and to his right is General Counsel Jamie Allen. We are going to begin today with three separate presentations: Anthem, Cigna, and Medicare on the waiting list. Each of these will run between 10 and 15 minutes, and they will cover both individual and small group plans to help cover both on and off the exchange market. After those presentations, we will hear a cost growth benchmark presentation from the Office of Health Strategy. Dr. Beaver Gifford, who is the executive director of that office, is here today. He's also the senior health policy advisor to the governor, and they did a tremendous amount of work for the past few years coming up with the cost growth benchmark, which will and the plan is to enable us to hold, as it said, the cost growth of healthcare down so that more people can have access. After this, the insurance department, me and John's staff, will have the opportunity to question the applicable companies. After the department has concluded its question, we will probably take about an hour. The Attorney General, the Office of Health Strategy, and the Office of the Healthcare Advocate will take another hour to the question of the business. Then we will hear from the chair and the ranking member of the Insurance and Real-Estate Committee, and other elected officials who have signed up to testify and then be allowed to speak will help to inquire. After that, members of the public who have signed up will each have 3 minutes. Now, I do want to mention for those who are in attendance here today, we expect that portion in public input to begin no earlier than 1 p.m. this afternoon. If you cannot stay on the event, please feel free to submit your information through the CID website. Submit your testimony, and that will be added to the records. Just for some housekeeping, when speaking, please begin by introducing yourself, and please address all your comments directly to me. To ensure everyone gets a chance to participate, please focus your remarks on the pending health insurance rate filings that are currently under review by the department. That is the focus of the hearing today. If you've already submitted written comments and plan to speak, I would ask that you provide a summary rather than simply restating the full written comments. Please mute your microphone when you're not speaking, whether you're on Zoom or here, and please silence your electronic devices for the entirety of this meeting. If you are in this room and you are speaking, please use the microphone when you speak. If you've got a microphone in front of you, please turn it on. That way, those who are viewing on CTN will be able to hear what you say. We will make sure that as many people as possible have input and the feelings and can hear what feedback. That's why we're doing it here. That's why we're doing Tuesdays and Sundays that we're. Now, this past March, the department released annual bulletin. The number, if you want to look it up, is HB 8123. And that outlines the health insurance rate filing guidelines for companies providing individual and group health insurance policies. Again, we invite you to take a look at the bulletin at the end with the questions, and that is available on the website. The CID reviews all rate filings in accordance with the applicable provisions of Medicare state law. The only standard on the law that we use to evaluate the rate request are that these requests not be excessive, inadequate, or inferior discriminatory. Under the Affordable Care Act, the minimum loss ratio, that is the ratio of benefits paid to premium for individual and small group coverage, is 80%. And because Connecticut's requirements align with the rate review requirements of the Affordable Care Act, the federal government has designated Connecticut as an effective rate review state. As a result, the federal government relies on the review by the CID of rate filings pertaining to all health plans, such as the HCA. The CID review of each filing includes a comprehensive actuarial analysis in accordance with the actuarial standards practice. Among other items, the team analyzes trend components, including unit cost, how much every particular piece of service does, utilization, how much those services are being used, and severity of the cost. While we also evaluate the trends against historical data from prior rate filings. Now, I would like to welcome the representatives from the three carriers we have with us today, and I will begin with Anthem. Brandon Rousseau, Sales Director for individual, small group, and commercial large group market, and Sue Nguyen, hopefully I'm pronouncing that correctly, is Director and Actuary for the East Region. Both are joining us. From Cigna on Zoom, we have Kristen Jordan, who is the Regional Vice President of the Central Region, Select Middle Market Segments. And we have our colleagues, Zachary Moon, who is Actuarial Director for Cigna and Oscar, and Jeffrey Thompson, who is Small Group Solutions Director for Cigna and Oscar, and they're both with us in person. From Connecticut, we are joined in person by Brandon Brett, who is the Vice President and Actuary, and Mark Needle, who is the President. We will begin by transitioning to the carrier presentation. That will be in alphabetical order. We can start with Anthem, followed by Cigna, and we end with Connecticut. Please begin.
Good morning, Commissioner Mays, members of the Department of Insurance, members of the Connecticut State Legislature, and Connecticut officials, and members of the public. Thank you for the opportunity to be here today. My name is Brandon Rousseau, and I am here on behalf of Anthem Blue Cross and Blue Shield of Connecticut. I serve as Anthem Sales Director for the individual, small group, and large group commercial segments. Joining me is Sue Nguyen, Anthem's lead in actuarial strategic planning. At the outset, I would like to say we understand and appreciate that the insurance department's charge of reviewing individual and small group rate applications is always complex. In an environment that continues to be uncertain, the department must ensure that the rates requested meet the statutory criteria requiring that they be adequate and not excessive or unfairly discriminatory. A stable insurance market is dependent on products that create value for consumers through premium rates built upon a known set of conditions that enable the broad spreading of risk. Anthem is here today to present our 2024 individual and small group rates. Anthem is seeking a 9.8% average rate increase for our individual plans, which ensure approximately 33,939 members, and a 14.9% average rate increase for our small group plans, which ensure approximately 27,565 members. What distinguishes Anthem is the balance we strike between national scale and local presence. This balance allows us to deliver industry-leading innovative products, distinctive service, simplified transactions, and world-class technology with the benefit of local expertise and experience from our 1,400 associates who live and work here in Connecticut. We have approximately 118 million members nationwide, with more than 1.1 million members in Connecticut alone. Anthem is proud to have been a part of the Connecticut healthcare community for 87 years. Last year, we contributed $1.3 million to community organizations in Connecticut, including the Governor's Partnership for Prevention, the American Heart Association, the 100 Club, the Juvenile Diabetes Research Foundation, the Ronald McDonald House, and the Make-A-Wish Foundation, just to name a few. Our unique business model allows us to maintain a strong local presence, including a fully dedicated Connecticut leadership team. Our local team understands and meets customer needs and builds positive long-term relationships with care providers and our community. Our provider network includes all of the state's general hospitals and over 30,000 providers, including PCPs, specialists, APRNs, physical therapists, and more. We would also be remiss if we did not applaud the administration and the legislature for the innovative program that was started in July 2021 called Covered Connecticut, which allows people of Connecticut with certain incomes to maximize their federal subsidies along with state dollars to purchase insurance for zero cost on the exchange. This is a critical program given the Medicaid redetermination that is currently underway. Anthem is committed to ensuring that people who are undergoing Medicaid redetermination find an insurance home if they are no longer eligible for Medicaid. And we have been working diligently in communities across the state to generate awareness about this process. In May, we introduced a team of 3 community relations representatives who have been actively engaging and partnering with Access Health CT, hospital systems and doctors' offices, municipalities, and community-based organizations, providing education and information in an effort to spread the word to those that will be impacted and ultimately lose their healthcare coverage. Over the last 10 weeks, our community relations team has attended over 40 community events and connected with dozens of organizations throughout the state of Connecticut. These activities will continue for the duration of the Medicaid unwinds, and we remain committed to empowering our local communities and educating the residents of Connecticut about their options to remain covered. Now, turning to our specific rate applications. They reflect what we consider to be the most significant challenge facing the marketplace.
And he was at first he didn't like it, at first.
As we have stated in previous rate submissions, COVID-19 generated uncertainty. While the use of healthcare services were down, we are now seeing the return of cost trends that were seen pre-pandemic, particularly in hospital spending growth as well as in pharmacy spending. We expect these trends to continue in future years. In addition, there are other factors that drive our premium request. Year to date, both medical and pharmacy costs are trending up as compared to the prior year. Declining COVID-19 related illness utilization is contributing to slightly favorable inpatient medical trends. However, this is being largely offset by a post-COVID demand utilization spike in procedural categories like musculoskeletal, which includes total joint replacements, and gastroenterology screenings, which include colonoscopies and endoscopies. Behavioral health utilization continues to run high across all service categories, including inpatient substance abuse disorder treatments and outpatient and office-based therapy programs. Finally, several mandated changes to comply with updated actuarial value requirements and the new legislation enacted by the legislature have impacted premiums. These include utilization review request timeframes, which shorten the maximum timeframes for health carriers to notify an insured of his or her authorized representative of certain utilization reviews. Step therapy prohibitions, which reduces how long an insurer can require an insured to use step therapy for prescription drugs from 60 to 30 days, and prohibits step therapy from January 1st, 2024 to January 1st, 2027 for drugs used to treat schizophrenia, major depressive disorder, or bipolar disorder. Insurance coverage for in-home hospice services, which requires certain individual and group health insurance policies to cover in-home hospice services provided by a DPH licensed hospice home care agency to the same extent they cover inpatient hospital hospice services. Other factors affecting our rates that are not directly related to healthcare costs include premium taxes and assessments to fund various state agencies and state-run public health programs, and dollars to underwrite the operations of the state exchange. While these programs and services might be the right priorities, they come with a cost that factors into rising premiums and cost sharing. For Anthem, these requirements equate to about 5 to 6% of our 2024 premium request. This does include the increase in the exchange user fee from 1.65% to 1.85%. While Anthem fully supports providing members with access to healthcare, these additional state mandates increase costs, with the individual and small group markets bearing the cumulative burden of these increases. Anthem has and continues to work to ensure access to affordable and quality healthcare. Anthem's commitment to transforming healthcare is built upon the foundational belief that by driving innovation, we can deliver greater value for our members and provider partners, and ultimately improve the sustainability of the system as a whole. The only way to truly generate affordability is by moving volume to value. When we work like this, not only do we make healthcare more affordable, but we also improve health outcomes. In plain language, we lower costs and people are healthier. The move to value requires a full suite of value-based payment and delivery models that complement and support one another, creating alignment across the entire delivery system. Here are some examples of what Anthem is doing with this philosophy in mind. Enhanced personal healthcare, or EPHC. Our flagship value-based solution aims to improve quality outcomes and control cost of care trends. Care providers in EPHC are incentivized for delivering quality, efficient care by focusing on prevention and wellness, offering personalized plans, and coordinating treatment across the spectrum of care. With EPHC, a fixed per member per month clinical coordination payment compensates PCPs for important clinical interventions that occur outside of the face-to-face visit. These services include care planning, enhancing access, such as responding to emails or offering web-based visits, or following up with patients via phone or email to make sure they fill in prescriptions. This type of proactive clinical coordination improves health and reduces costs. The second part of the payment model and our shared savings payments that reward providers when they meet quality measures, and the actual cost for their attributed patients are below projected estimates. Our EPHC program includes 14 accountable care organizations with over 3,500 PCPs and provides services to over 400,000 members. Our data shows that our value-based care provider partners conduct more annual wellness visits with our consumers on average, reducing emergency cases and inpatient admissions. Oncology Medical Home Plus, or OMH Plus. OMH Plus supports medical oncologists in the shift from volume to value for consumers undergoing active chemotherapy treatment. Oncologists are incentivized to align treatment with patient goals, follow evidence-based care plans, reduce cost of care through comprehensive management of chemotherapy regimens, and support patients through transitions of care in various modalities. We support care providers by offering digital resources, population health analytics, and practice transformation tools for improved decision-making. OMH Plus care provider partners are encouraged to improve patient outcomes through value-based cancer care pathways rooted in evidence-based medicine, lower cost of care through appropriate use of services, and improve consumer satisfaction through better coordinated cancer care and avoidance of emergent care. Episode-based payments. These bundled payments encourage cost-effective coordination between primary care, specialty care, and ancillary health services by asking specialists to be accountable for cost and quality outcomes for a consumer's entire episode of care. This payment model combines payment for the full continuum of care surrounding a procedure. This drives down care fragmentation and supports improved outcomes for high volume, high cost specialty care such as pregnancy, joint replacements, and colonoscopies. Quality Insights Hospital Incentive Program. This is a performance-based reimbursement program that rewards hospitals practicing evidence-based medicine and meeting overall quality measures for patient safety and outcomes. Member engagement is critical to the success of healthcare affordability and improved outcomes. This is why we continue to develop and offer a suite of products, programs, and solutions that encourage members to align with high-performing providers and engage in the right behaviors that improve health. Anthem is committed to delivering access to the highest value healthcare to the consumers, employers, and government customers we serve here in Connecticut and across the country through greater affordability, higher quality, and choice. We believe the private sector is best positioned to accomplish these objectives. To that end, we encourage support for the following recommendations. Addressing anti-competitive contracting practices. Connecticut made progress this year by passing legislation to address anti-competitive practices by consolidated health systems such as all or nothing, anti-tiering, and anti-steering clauses in provider contracts. These reforms will enhance competition among providers and create an opportunity for health plans to engage in access and network innovation. Expanding access to care. Advances in telehealth have made significant impacts on access and affordability for Connecticut consumers, particularly in behavioral health services, which has been enabled by Connecticut policymakers. Continuing to work on Certificate of Need, or CON reform. Anthem recommends that the legislature and governor continue to work on CON reforms to ensure that hospitals demonstrate a need prior to increasing capacity. Unnecessary expansion results in hospitals needing to cover larger fixed costs, and that supply can create its own demand in an environment where charges are paid by third parties. However, CON reforms must also ensure that competition cannot be blocked in the market. Require hospitals to bill accurately on professional billing forms and in claims standards so the insurers can apply the correct professional reimbursement rate. Enacts legislation to require public reporting of all private equity or hedge fund purchases and investment in air or ground ambulance providers or facilities, emergency room physicians, and other specialty groups where there is evidence of high levels of concentration or low levels of network participation. Enacts legislation for state review of hospital and healthcare provider consolidation. Consolidation of previously independent provider groups under a single hospital system is driving up the price of healthcare services. These are the same services provided before and after the consolidation, with the exception that the consolidation under the hospital system can trigger higher contract prices for payers. Expanding the scope of practice laws for mid-level practitioners is another way to increase competition among providers, which would put downward pressure on payment rates and ultimately reduce growth and costs. Enact the following prescription drug reforms. Prevent harmful markups and increased costs for patients by protecting the use of specialty pharmacies to access lower drug costs. Address drug manufacturers' abuse of charitable structures. Increase drug cost transparency by requiring price disclosure from drug manufacturers at the time of launch and at the time of list price increases, and requiring disclosure of patient assistance programs. Roll back any willing specialty pharmacy laws. Payers use several tools to ensure quality care and contain costs. Any willing pharmacy requirements in Connecticut limit Anthem's ability to do both. Lastly, employers, individuals, and families purchasing health insurance coverage entrust health plans to manage care and ensure that members receive the right care in the right setting at the right time. Today, vital tools used by health plans at the request of insurance purchasers are under attack. Utilization management. Limits on insurers' ability to conduct reasonable utilization management drive up the cost of healthcare and negatively impact the quality of healthcare services. Benefit mandates. Connecticut requires coverage for more than 64 specific treatments or services, including some that go beyond evidence-based guidelines recommended by major national health organizations. While the cost of some mandated benefits in isolation may be relatively small, their collective impact drives up the cost of insurance coverage for every person in Connecticut. Prescription drug coverage mandates. We know that drug prices continue to increase, and drug costs are the second highest expenditure of the healthcare dollar next to hospital costs. In Connecticut, constraints on mid-year formulary changes enable drug manufacturers to raise the price of prescription drugs, driving significant cost growth while restricting payers' ability to contain costs. We trust that the information presented during this hearing will assist the Department of Insurance's review of Anthem's rate application. As already noted, Anthem, like all health insurers, is required to have rates that are adequate and not excessive or unfairly discriminatory. We take this obligation seriously. Offering products at adequate rates to cover the underlying risk of the population served is necessary to meet our members' commitments and ensure market stability. We welcome any questions the department might have. Thank you.
Thank you, Anthem. And before we go on, I do want to remind those who may be in the room, wish to comment, and are not able to stay for the public comment here at the beginning of today, then you can file your written comments at cid.ratefilings@ct.gov. That's cid.ratefilings@ct.gov. You can do that today, and you can do that over the next few weeks.
That email isn't working.
cid.ratefilings.
And I did post on Twitter and Instagram. I attempted it several different times with 3 email addresses.
We will review
Both
that.
capitalized and lowercase.
Sorry about that. I was not aware of that. We can do that in the process. And we hope you will submit. Now, let's move on to the next presentation, as I mentioned, alphabetical, and Cigna will be the next presenter. Cigna.
Good morning, Commissioner Mays. I'm assuming everybody can hear me okay. My name is Kristen Jordell. I am the Regional Vice President of Sales with responsibility for the Connecticut market. I've been with Cigna for 17 years and reside in Connecticut, although I apologize for not being able to attend today's meeting in person as an unavoidable conflict required me to be out of state today. I really appreciate the opportunity to connect with you virtually this morning. With you in Hartford today is Zach Moon, Small Group Actuarial Director for Cigna Plus Oscar, and Jeffrey Thompson, Small Group Solutions Director for Cigna Plus Oscar. We appreciate the opportunity to come before you today to present the reasoning and methodology associated with our 2024 rate filing for our Cigna Plus Oscar off-exchange small group offering. We especially appreciate the work of the Department of Insurance and many others in the room toward our shared goal of ensuring high-quality, affordable health coverage for Connecticut's small businesses and their employees. Although we are here with a request for a rate increase, our premiums, the amount small employers actually pay out of pocket, continue to be competitive in the marketplace, even after this rate increase, compared with other requested carrier rates. To that point, our premiums continue to be lower than the market average for silver plans, which are the most popular among small employers, and we have the lowest average cost silver plan in 6 out of the 8 rating areas, representing the vast majority of where small employers are located. The Cigna Group is a global health company, proudly headquartered in Connecticut, with over 70,000 employees worldwide, including more than 4,000 of us here in Connecticut. Through Cigna Healthcare and Evernorth Health Services, we are committed to enhancing the lives of our clients, customers, and patients. Cigna maintains sales capability in over 30 countries and has over 100 million customer relationships throughout the world. As you likely know, Cigna Plus Oscar is still a relatively new offering in Connecticut, coming to market in 2021. We recognized the need for more innovative, more affordable solutions for our small employers, and we partnered with a newer, innovative health company, Oscar, to bring together our collective best to offer a product that delivers superior value and a differentiated service experience. Our Connecticut small employer clients and the brokers who support them highlight to us that our model, which is unique in the small group market, help make Cigna Plus Oscar easy to do business with and a preferred choice for health insurance for them and their employees. I'm proud to say that in a very short time, Cigna Plus Oscar has become a popular choice with our small business employers. In fact, Connecticut has been our fastest growing small group market in the nation. We are on track to achieve 25% market share in Connecticut by the end of this year. Small employers can and do have a strong voice in the market by choosing who they use for healthcare coverage. Cigna Plus Oscar is proud to be their partner of choice as we continue to offer competitive market premiums across the state. Finally, we also acknowledge there is more work to do. Cigna Plus Oscar team and the larger Cigna company team recognizes it has an important role in helping make healthcare more predictable and more affordable. Cigna has been engaged and will continue to collaborate in industry, provider, and community forums to help identify and implement workable solutions for all parties across the healthcare universe to the benefit of Connecticut employers and their valuable employees. Cigna Healthcare is focused on delivering healthcare that is affordable, predictable, and simple, so people can live healthier, more vibrant lives. Still, with affordability and access challenges and crises of mental health and care disparities, there is so much more that can be done to strengthen the system so that it works for everyone. Patients, providers, and employers deserve an efficient and integrated delivery model that creates and rewards quality outcomes and supports private sector innovation to best serve the patient. As policymakers pursue strategies to improve the healthcare system, Cigna Healthcare is committed to engaging on public policies that drive choice and affordability, foster innovation, demand quality, and improve access. Thank you.
Good morning. My name is Zach Moon, and I'm the Small Group Actuarial Director for Cigna Plus Oscar. I'm a fellow of the Society of Actuaries and a member of the American Academy of Actuaries. I'll first address the Cigna Plus Oscar product offering and then get into what our average percentage increase actually means for our premiums. Finally, I'll compare that to our competitors in the marketplace to provide a more complete picture. In 2024, we will offer 21 plans across all metal levels, including 5 HSA plans, which represents an increase in plan choice from our 2023 plan portfolio. These plans will continue to offer competitive rates for our price-sensitive small group buyers statewide. We offer a broad, quality network of trusted physician and hospital partners that small group employers and their employees value. As part of the differentiated solution that we bring to the market, we have an innovative customer service model dedicated to Connecticut small group customers that includes a dedicated Cigna Plus Oscar care team that is supported by a clinician and simple digital tools to guide customers to high-performing Connecticut physicians and hospitals. Our plans include $0 copays for virtual care and access to a $3 copay drug list that helps reduce drug costs for as many as 88 common conditions, such as blood pressure, cholesterol, migraines, and diabetes. We offer convenient home delivery of prescription drugs that can be enabled with a click of a button. We leverage the expertise and efficiency of Cigna's Express Scripts to provide customers with the right drug, at the right time, at an affordable cost. Furthermore, our plans reflect the importance of comprehensive whole person health, connecting the mind and the body. We include access to our full behavioral network and no charge access to our specialized behavioral and health coaches for personalized help, managing conditions like depression, eating disorders, bipolar disorder, autism, and others. These are just a few examples of the features in our innovative plan design portfolio. For 2024, we have requested a 23% average increase, which varies plan by plan. This increase is driven by a number of factors. Approximately 12% of the rate increase is related to updates to our baseline assumptions, including updates to our claims experience and risk adjustment chart, and a reset to our baseline rate development assumptions to best estimate for 2024. Healthcare trend drives the second largest component of our requested increase. The remaining factors of our rate change include benefit modifications to comply with updated actuarial value requirements and changes in operating expense expectations. With this increase, we project our ACA medical loss ratio to be 87% for 2024. Even with Cigna plus Oscar's 23% average increase, our premiums continue to be lower than the market average for silver plans, which is the most popular metal choice among small employers in Connecticut. We have the lowest average cost silver plan in 6 out of the 8 rating areas, representing the vast majority of where small employers are located. Thank you. We're happy to take your questions.
Thank you, Sigma, and finally, let's move on to Connecticut.
So good morning. My name is Mark Fetter, and I am president of Connecticut. By my side is Brandon Rip, who is, as Mr. Commissioner Mays noted, is vice president and actuary at Connecticut. We appreciate the opportunity to appear before you today to discuss the underlying costs of care that drive our requested premium rate increases in the individual market. There are 3 points we want to make today in the discussion. The main point is that the amount we pay to hospitals, pharmaceutical companies, and other healthcare providers drive the cost of care to our members. These costs are increasing as hospitals, pharmaceutical companies, and providers are demanding higher reimbursement for the healthcare services and supplies that they provide to our members. Our filed rates reflect these increased costs. We have requested rates that are necessary to continue Connecticut's mission to create healthier futures for our customers and the communities we serve. That mission started when Connecticut was founded in 1981 by a group of physicians seeking to offer a better health insurance option for employers, residents of our state. We offer plans for large and small employer groups, plans for individuals and their families, and plans for retirees and other individuals eligible for Medicare. As a reminder of Connecticut's commitment to the state and its residents, after the passage of the Affordable Care Act, Connecticut stepped forward to become a part of the new health insurance marketplace here in Connecticut. We have renewed that commitment year after year, as some of the large carriers have refused to participate, citing that allowed premium would not be adequate. As a result of our deep commitment to the state, today Connecticut covers 70% of the individuals purchasing health insurance through Access Health. We understand well that for many individuals and families we serve, the individual market is the only option for accessing the health coverage they need. And we continually strive to make coverage as affordable as possible within our state's competitive landscape. Please allow me now to directly address the question of our requested rate increases for 2024. For an insurance company to be sustainable, rates must be adequate to provide for the payment of claims and the cost of administering the program. Over the past 2 years, we have experienced significant losses. We have been transparent about those losses. Last year at the same rate hearing, we explained that we lost $65 million in the individual market in 2021. In 2022, we lost $36 million. In 2023, our financials have improved, but we still expect to run at a loss in the individual market. For 2024, the premium levels for our plans must be sufficient to meet the healthcare needs of our members who depend on us. Our proposed rate increases in the percentage terms reflect the healthcare cost of 70% of exchange members we serve. However, in real dollars, the resulting 2024 rates would remain among the lowest in Connecticut's three largest counties, where a silver medal plan, our most popular plan. Bringing Connecticut residents some of the lowest rates in the market for 10 years demonstrates Connecticut's commitment to making health insurance available to the residents of our state. As alluded to above, the significant driver of our requested premium increases is medical trend, which is the increased cost of reimbursing healthcare providers for the services they provide to our members and the utilization for their services, such as emergency room visits, hospitalizations, office visits, radiology, and prescription drugs. On the cost side, some health systems in our state have requested that we increase their contract reimbursement by 3 times the state's cost growth benchmark. Some hospital systems are getting larger and larger, buying up other hospitals and physician practice. The hospital system consolidation in our state has made it more difficult for us to negotiate reimbursement rates on behalf of our members and our customers. To achieve the state's cost growth benchmark of 2.9% in the individual market, the underlying cost of care must be reduced. Connecticut's healthcare providers need to be held accountable for increasing their charges, just as the state's insurance companies are being held accountable. Unfortunately, insurance companies alone cannot control the underlying cost of care. Addressing affordability requires participation and partnership from all parties, carriers, drug companies, consumers, and the state. One of the ways we are addressing cost and quality is by promoting primary care. Connecticut has embraced the state's point of view that increased access to and utilization of primary care is vital in maintaining good health and preventing catastrophic conditions. For example, we were one of only 2 carriers that achieved the Office of Health Strategy primary care spending target to put more resources into primary care. And we have an ongoing effort to encourage our members to select a primary care physician if they have not already done so. We have also added rewards to encourage members to seek preventive care and regular tests and procedures. And we have implemented a program to allow our members to receive comprehensive primary care virtually to meet the evolving ways our members access the healthcare system. Connecticut has always been and continues to be proactive in managing costs. We work with hospitals, doctors, and other medical providers to help control costs and improve healthcare outcomes for our members. The rates we have filed reflect the following steps that we have been taking. We are engaging medical providers throughout the state in accountable care organizations and other value-based arrangements. We are expanding our oversight to promote evidence-based care for our members. We are investing in disease and care management capabilities that target members at high risk for chronic conditions, with a focus on social determinants of health and the diverse cultural needs of our members. And we are accelerating the delivery of well-being and disease prevention programs through our affiliate company, WellSpark Health. In addition, we partnered with the state to develop solutions that reduce costs, expand access, and create better health for our community. These include supporting the Covered Connecticut program, which leverages Access LCP to provide no premium, no cost share plan design to certain low-income consumers who are not or are no longer eligible for Medicaid. We are actively working with OHS on the health cost growth benchmark. And we are working with OHS to drive more primary care. Throughout its 40-year history, Connecticut has worked to be a strong partner to our members, to the state, consumer and business community, doctors, and other healthcare providers. Our message today has been that our requested rate increases reflect underlying costs that must be addressed for Connecticut to maintain a viable plan offering for our individual partner customers. It is also important to note that as a plan directly focused on this community, should we achieve a surplus, we can reinvest those dollars in the community through our charitable giving, our ongoing efforts to improve the experience for our customers and our consumers, and invest in reducing healthcare disparities in our community. We are not a publicly traded company, so we have no individual shareholders to satisfy. Furthermore, any surplus that exceeds the regulatory limit for insured products as set forth by the Affordable Care Act's medical loss ratio rule is returned directly to those who pay the premium. Looking to the future, we are committed to working with legislators, state officials, providers, and others to address affordability and consequences of healthcare disparities. Together, we can improve our state's strong healthcare and create a system that is accessible and affordable to all. These improvements to the system will take time and cooperation, and we will do all we can to influence real change. We hope to continue to be the partner you depend on when we consider our responsibility during this process to be transparent about the premium we need going forward. In short, we have not requested any more than we absolutely need to continue serving our members. We appreciate the thoughtful review and consideration that we are confident will be given by the insurance department as they review our fact and data driven rate request. We appreciate this opportunity to explain our filing and look forward to your questions. Thank you.
Thank you, Connecticut. Thank you all for testifying today. For those who've been listening, I've heard a number of references to the cost of benchmark, which is one of the tools we, the Department of Administration, are trying to use from the giving cost of the world and the cost of healthcare. Now, instrumental in this has been the work done by the Office of Health Strategy and its executive director and the health policy advisor, Dr. Gifford. I would now have to turn it over to Dr. Gifford to provide us with some information on the cost of benchmark. Dr. Gifford.
Thank you very much, Mr. Mays. Very happy to be here. Good morning, everyone. I'm Dr. Gifford, Director of the Office of Health Strategy. We appreciate the opportunity to talk a little bit about our cost growth benchmark result in the context of the review of these filings this year. I'm just going to do a brief overview this morning, start with a little background on the benchmark itself. A few facts about the impacts of high healthcare costs in Connecticut on our residents. Then I'll describe our benchmark results and a few of the drivers, some of which you all have alluded to. And we do appreciate all of the collaboration and coordination with the carriers in Connecticut. We can't produce the benchmark data without you and your team. So we appreciate working together as we all tackle these very challenging issues. So the cost growth benchmark was originally begun by Executive Order Number 5, just on the eve of the pandemic, January 2020. And at that time, the Office of Health Strategy under the leadership of Vicki Beltry set benchmarks for 2021 through 2025. Then in the 2022 legislative session, the General Assembly passed House Bill 5506, which put the healthcare cost growth benchmark in the statute. Next slide. The benchmark has an annual cycle. And beginning this year, which was our first reporting year for the benchmark, OHS must report the findings of our benchmark analyses, including contextualization, which is important, by March 31st of each year. So we did produce our first report earlier this year. It's available on the OHS website. Then in May, we must identify and notify provider entities, including insurers, that exceeded the benchmarks and send official notice to each within 30 days. So that process happened in May. And we also had the opportunity to identify other significant contributors to the benchmark and notify them as well. Then in June, OHS has the opportunity to hold a hearing during which those entities we notified on May 1st and come before the office to talk about the benchmark results. This year, we've had representatives from insurers, hospital systems, and drug manufacturers, as well as a roundtable with physician practice groups that gave us some very important information about how they are addressing the benchmark results. And then right now, we are in the process of producing a report for the legislature, which is due to them by October 15th this year and every subsequent year, providing recommendations on ways that we can address healthcare spending trends, our plans for monitoring any unintended consequences of the benchmark program, and our recommendations to the legislature for increasing the efficiency of the state's healthcare system. So we're in the process of producing that report now, and we'll have done so by October 15th. We are now one of 8 benchmark states in the country, so Massachusetts was the early leader in this area, and they've subsequently been joined by 7 others. This gives us the opportunity to not only look at our own trends, but to compare our cost growth trends and the underlying data with states around the country, which has been very useful. These are the 4 components of the benchmark legislation. You heard Mr. Meadow refer to our primary care spend targets, so we're reporting those beginning this year. We also will be reporting on quality benchmarks as well as measures of health equity. Next slide. So in context, this is a slide that just compares the average Connecticut family premium in 2021 to some other costs that most people can relate to. A family premium in 2021 in Connecticut was more expensive by quite a bit than a private child care for an infant, and more expensive than a compact car at about $24,000. Next slide. Some of you may have seen a release that the office put out week before last about the Commonwealth State Scorecard. And the state scorecard is put out every year, and it's a measure of healthcare system performance in every state in the country. Connecticut overall performs very well in terms of access and quality, but we perform very poorly when it comes to the cost of employer-sponsored insurance. In fact, we rate in the bottom at 46 in the cost of, or the spending for employer-sponsored insurance per enrollment. So this is the rate of growth in healthcare spending compared to the other benchmark states that I mentioned. This is the 2020 to 2021 commercial total medical expenditure trend per member per year by state in commercial spending. And you can see that Connecticut was the highest at 18.8%. Our benchmark is down towards the bottom of those blue bars at 3.4%. We rated higher than Delaware, Massachusetts, Oregon, and Rhode Island. So one of the ways that we set our benchmark in Connecticut at the advice of a stakeholder advisory group was to look at a combination between projected economic growth and median household income. So what we see in 2021 is that commercial healthcare spending grew by 18.8% in Connecticut, but median household income increased by only 1.9%, meaning that the growth in commercial healthcare spending is far outpacing the growth in what's in households' pockets to spend. This is a screenshot from the Urban Institute, which reports on the percentages of population that are carrying medical debt in collections. So the numbers are a little bit smaller. You can go to their website to see it. But what this says is that in Connecticut, 10% of the overall population has medical debt in collections. That's slightly lower than, I believe it's, I can't see, I think it's 14% or 13% is the national average. But 14% of people of color in Connecticut have medical debt in collections. So medical debt is disproportionately impacting individuals of color in our state. We also know that people with multiple chronic illnesses and disabilities are disproportionately impacted by high levels of medical debt. So there's a relationship between the increase in costs, the increase in household income, and the amount of medical debt that we're seeing in our state. Next slide. And this is a survey from last summer, summer of 2022, surveyed 1,300 Connecticut adults. Over half of those surveyed reported experiencing at least one healthcare affordability burden in the last year. 78% worry about affording healthcare in the future. And as I mentioned, lower income residents and those with disabilities were more likely to go without care or to incur debt due to healthcare costs. And importantly, I think the respondents strongly agree that leadership in the state should take action to lead solutions for this challenge. Next slide. A few more of the findings from this survey. 1/3 of uninsured respondents cited cost as a reason for not accessing health insurance. Nearly half of all respondents reported delaying or going without some sort of health care during the prior 12 months. And 1/3 had experienced one or more struggles paying. Next slide. So here are our benchmark values. The benchmark was set at 3.4% in the 20 to 21 year. Will be 3.2% for the 21 to 22 year, and then 2.9% for the subsequent 3 years. As I mentioned, the benchmark values are based on a blend of the forecasted per capita potential growth state product and forecasted growth in median income. Next slide. So this is our result of our first cost growth benchmark report. And of course, it bears saying something all of us in this room know, which is that the 20 to 21 years were not effectively spending years in healthcare. We saw declines in spending in 2020, as you can see on the far left bar. And then we saw a rebound in spending in 2021, as you can see in the middle bar. So our overall cost growth in the state was 6%, exceeding the benchmark of 3.1%. Next slide. But what this slide demonstrates is that their commercial spending rebound was far in excess of that in Medicare and Medicaid. We look at cost growth not only overall, but also by market. So you can see that there was a modest increase in Medicaid and Medicare spending. Those are the 2 bars on the far right. And then a much larger growth in spending at 18.8% in commercial spending. And that's the bar, second bar from the left on the right-hand side of the slide. Next slide. You can see here this divides our spending by market, commercial, Medicare, and Medicaid, and you can see that commercial spending is the largest share by cost. And you can see that we have had a growth in approximately $2 billion in healthcare spending between 2019 and 2021. Went from 31.9 billion to 34 billion over that 2-year period. Next slide. This is the performance by commercial payer. And you can see that all of the commercial payers represented here today exceeded the benchmark by pretty wide margins. United Healthcare had the lowest, and Anthem was the highest at 18.9%. Next slide. And this is, I think, helpful context just to look at our prices. Some of you mentioned the price of healthcare in Connecticut as a primary driver for your rate filing. Our prices in Connecticut metro centers are higher than the national average and elsewhere in New England. This is data from the Healthcare Cost Institute, comparing how much we exceed the national average to our neighboring states of Massachusetts and Rhode Island. So you can see that, as we all know, healthcare costs in New England are higher than they are elsewhere in the nation, generally speaking. But Connecticut's prices are even higher than those in Massachusetts and Rhode Island. Next slide. And this is true for both hospital inpatient. You can see we exceed averages by 27, 38, and 45%, whereas Massachusetts exceeds the averages by smaller amounts and the same in Providence. Next slide. And this is the analog for the hospital outpatient market, where we are also higher than the United States. And I think I have one more slide. Two more slides. This is just to mention that, as I said earlier, our quality performance in Connecticut is something of which we can all be very proud. But our higher prices are not buying us higher quality in our neighboring states. This is how we rank on prevention and treatment from the Commonwealth scorecard. So we ranked fifth, something of which we can be proud, as I said. But our neighboring states that is going to be less on healthcare ranked more highly than we do. Next slide. The final thing I wanted to mention is about our prices, particularly for hospital services, which all of you mentioned as primary driver in your filings. There's a tool that's available online from the National Academy of State Health Policy, which uses all payer claims databases to compare hospital costs around the country. What we see on that tool is there is a very large variation in what's paid for hospital services in our state. The lowest price hospital in Connecticut is paid at approximately 170% of the Medicare price. We're using Medicare as a benchmark, looking at commercial prices. The lowest, there are several hospitals that are grouped between around 165 and 180% of Medicare. The highest price hospital in Connecticut is paid almost twice as much at over 300% of Medicare. And it is not possible to explain, at least using the CMS hospital compare tool, it's not possible to explain these variations in price based on quality differences. So that concludes my summary of the cost growth benchmark. Commissioner, thank you very much.
Thank you, Dr. Gifford, and yes, I provide some merits for us, I think, as we continue on discussion here today. I'm now going to start a question, and as the whole begin the question. My initial question, so I've got a couple of questions, but I would like everyone to answer. Look, I'm listening to Dr. Gifford, looking at her presentation, and some numbers jumped out. As I'm sure they did at those people watching. 18.8% increase in medical costs and healthcare spending. When GDP to the average salary, I think it was 1.9. 78%, that's more than 3 out of 4, almost 4 out of 5. So take a look around here, almost 4 out of 5 the people in the room, the state, worrying about healthcare expenses. 2.9%. That was a benchmark for this year. That's the benchmark. Every company has come to higher prices. And I know there have been moves made. I know that you've heard into some of the notes that I was stating here. As I listened to your presentations, I heard that the underlying cost of care must be reduced. I heard that the cost trend is driven by hospitals and drugs. And I heard the consolidation will trigger higher contract prices. Yet I come back to the fact that we have before us double-digit increases today, and that is higher than inflation and higher than the cost of the benchmark established by the Office of Health Care. Now, we rely on the self-insurers and negotiations with these hospitals. You don't have the individual market how to do so. We want you to do that. But I keep thinking you're going harsh enough things with water. Who will say that unless we want to just walk away, you're never going to get the right price. And if you look at the price of that director Gedward show for hospitals, is there a point at which we are not going to check that holding the providers accountable for unity as we say that he's supposed to be doing? If your premiums are going up in double-digit increases because of these bills, and if that is higher than the hospital benchmark that this administration proposed to give you to help you, how do you justify that? What do you tell the consumers who will be the best who say, I said, you know, I can't negotiate with my boss to get 15%. What do you do? But you know, I'm just looking for purely human level of your reaction. Let me start with that.
So Commissioner Mays, we agree with you. And I think there does come a time when you have to walk away from those pieces. And, you know, we almost did that with one system this year. And I think we need to be tougher, maybe start excluding some of the hospitals that are not high enough value for our customers. So I think that is something that all carriers should look at. You do need to have that negotiating power at the end of the day. Now, you know, we are not a national carrier, but we're smaller local health plans. We may not have the market power or the negotiating power that some of our competitors here, but we will do everything we can to try and reduce the cost of care. We will negotiate as best we can.
Thank you. Segment war.
Yeah, before I start, Commissioner Mays, I think that Kristen is having a little bit of trouble hearing you on the Zoom.
Sorry, before I just turned the mic back on, and as I was saying, signals there is a.
Absolutely, I appreciate the question. We certainly see hospital costs as a major driver of our underlying trend, part of each of the specific years. Our provider network and contracting teams work diligently every single day in order to bring the best cost for the consumer into our plans specifically. However, there are also multiple different facets beyond just the underlying cost of the contract. We continue to see rising utilization as well as added technologies that contribute to the mix of healthcare services beyond just the cost. As part of our experience trend that we saw in our 2024 rate filing, we actually saw increases in both the utilization as well as the cost, which is the piece that is driven by the hospitals, the provider systems, physicians in the state of Connecticut. And the utilization mix exceeded the amount that we saw from an increase in our expectation between last year to this year. So not only are hospital and provider systems driving these components specifically, but at the same time, we also are seeing an increase in the amount of services that are being utilized, the types of services that are being utilized within the state. So to just wrap, I would say we are very much focused on continuing to drive affordability via our provider costs within the state specifically, and continue to do so with the major health systems throughout the state. So I appreciate the question. Thank you.
Before I move on to end, let me just follow up that you mentioned an increase in utilization. That either means more people using services or people using more services. Is this greater than?
The current utilization trend that we have priced into our filing for 2024 is about 4.1%, which is greater than what we were experiencing before COVID. However, I will mention that we were not the Connecticut small group insured prior to COVID. And so at least from historical national data, we can see that the utilization has been higher. We have seen it decrease in recent years, especially after the spike of deferred utilization that came back from 2021, 2022. And our expectation going forward is that there will be a continued decrease as COVID-19 costs diminish over time.
Thank you. Let me turn to Andrew.
Yeah, I'll start, Commissioner May, by saying, I think our negotiations with hospitals are difficult every year. I think we go through very difficult exercise here. And I mentioned this in some of my testimony earlier. Our focus truly is on delivering value-based care. So we've made a really, a lot of great strides in getting that done with some of the bigger hospital systems here in Connecticut as well. So I think that's a big component of it. I can't stress enough how important it is to change away the model from fee for service and getting over to a value-based arrangement where you're rewarding providers for the activity of driving better care for our consumers here in Connecticut. We are fighting for transparency. We're trying to provide as many utilization tools as we possibly can. We have a mobile app called CID that really does kind of drive our consumers that are out there looking for lower cost, better quality opportunities. They can find that information as members through our website and through our mobile app. So a lot of the things that we've been doing, a lot of the investments that we've had into our technology-based, value-based opportunities for consumers is really driven towards that. Show the transparency. We're fighting the fight on the hospital side, obviously, to make sure that they're driving value, but at the same time providing that information to consumers on a regular basis.
In terms of providing a database, so we get paid for every pending proposal for individual services, which should be able to reduce individual costs. What's stopping that? What's stopping
From my, in my opinion, I think it's still relatively new to Connecticut. I think we're still looking, if you look historically, we've been so stuck on a fee for service based structure. I think we're trying to push and move towards this new model. And we have seen the hospital, quite frankly, adopt some of this, especially in recent years. Right now we're in hospital negotiations right now, and that's a big part of the conversation as we move forward.
Not sure you're just on the spot.
Yeah.
We saw that one of the final slides that were Dr. Deborah showed. And we're looking at the cost comparison between. Now, presuming that all parties and I'm also presuming that most of those states are not significantly more expensive. Why is there a delta difference between those hospitals and the what you get and the following?
Yeah, for me, it's a difficult question to answer. I think you can speak the same kind about almost anything here in Connecticut. It feels like whenever you're traveling outside the state, I was just down in Long Island. I think New York is probably a little bit different than us, obviously. But whether you're here in Connecticut or throughout the state, I think you see the cost of healthcare increasing regardless. Here in Connecticut, for whatever reason, I think we maybe started with a higher base point. But that's the fight that we're trying to fight. We're trying to drive the value-based care to kind of bring that overall cost of care down. I don't have an answer for you, unfortunately. It's why Connecticut gets higher than other states.
Thank you. Let me just go to question 2, and tell you I'm going to start sitting and get on the spot. We're going to get there, everybody again. But if you look at the people around the table, us being here before, on a number of occasions over the past couple of years, we've been holding public discussions here on the cost drivers of healthcare. We've had and you participated in insurance and hospital representatives, professional organizations, invited to participate. And we supported these discussions because we are serious in wanting to not only identify the cost drivers as we've got here today, but to help facilitate solutions that slow it down or decrease it, what eventually cost. Now, after all these discussions, after all this, what initiatives have come when so far, and what do you see as being likely to implement that will help consumers? And again, I'll start with saying,
Yeah, I appreciate the question. We certainly are taking multiple initiatives, whether it has been in the past year or as we look forward to 2024 specifically. We called out a number of these initiatives and actually included a reduction in our claims cost as part of our 2024 filing to improve affordability of our products within the state specifically. Some of these, as an example, we're activating enhanced prescription drug fraud, waste, and abuse controls. We are implementing a complex claim review program to ensure accurate and appropriate charges for inpatient services and supplies. We're also rolling out an oncology care management program that will partner with both customers and their physicians in order to lower avoidable hospital stays and to other post-discharge costs. Finally, we are also looking at emergency room level of care edit programs to ensure that the charges that are coming from an emergency room are both accurate and appropriate for the level of care and services. All in these initiatives that we have implemented or are planning to implement for the upcoming year are expected to reduce overall paid claims costs by about 2 to 3%. We've included that as part of our filing. I will mention that this is a limited list. We are absolutely looking at doing more things beyond just the Cigna plus Oscar program. And I might ask Kristen if you have additional items to add from a broader perspective for Cigna in terms of what we're doing to drive affordability, both within the state and the national.
Thanks, Zach. I appreciate the opportunity. Just two things I would put out there to the group. And I think they've been well articulated by my colleagues from Anthem and Connecticut, but I don't think we can underestimate the importance of driving messaging around primary care. And the way in which we do that at Cigna is very transparent, very communicative, and the long-term effects of that are still being seen and will continue to be seen into the future. So I think encouraging customers to get primary care taken care of is incredibly important. I would also mention things like biosimilars and refining and enhancing our pharmacy formulary to get at pharmacy costs is important. And lastly, if I think about technology, we've mentioned that briefly, but the investment that we can make in technology to advance things like telehealth, I think will impact in the short term and in the near term more than any other initiative that we can drive. So just wanted to layer in those two extra ads there. Thank you.
thank you. Let me
So, in my statement, I sort of listed all the things we're doing to try and reduce the expense of healthcare. But I do want to emphasize as well, value-based care is the way we think we all need to go in a state. So we need providers to take risk, we need to pay for outcomes, and not just pay for every service that is performed. So we are doing that today, but we need to go a lot further in value-based care. That is the transformation that we expect to happen. We also have, the cost of growth benchmarks, which, frankly, if we could have some additional teeth to that on the provider level, and there's some other states that are thinking about this, like Massachusetts, Oregon, even California, where they're actually putting penalties on providers if they don't meet the benchmark or have these performance plans. So there are some things that they could do, the entire ecosystem to really improve and reduce costs.
Before I move to Anthem, let me just get you a follow-up question this week. You mentioned teeth and cholesterol benchmark. Is there anything else, or what else can we as regulators, legislators, we and government do if the idea of value-based payment doesn't want that running for the rest of us and you help getting that?
So some of the things that have already been done this year help with the restrictions on anti-competitive contract language. That is helpful. If there's additional contract provisions that could be prohibited, If there's something we can do to reduce consolidation of the hospitals, some of these hospitals, I mean, right now we have network adequacy standards that we have to meet. And if you have, one hospital system that has half the state, it's hard to meet those standards. So, maybe there could be something done about the network access standards for these very large hospitals. So, I mean, I think there's a lot of ideas we can come up with, and we're certainly excited about working with departments and policymakers on that.
Thank you. Let's move to Anthem.
Yeah, I know there was a session, I'm trying to figure out, I think it was the benchmark public hearing it was earlier this year, mid last year. And I know there was, this is my opinion, I think that if you bring everybody together in a room in a facility like this, having that open dialogue is really how you're gonna get to that. Everyone's gonna say their own side, everyone's gonna have their own opinion about how to make this thing right. I think we as the insurer are doing everything we can to drive that change, but getting everybody together and speaking together, really, it's really gonna turn that off.
Thank you. Any other comments? In that case, let me turn it over to the department for their questions, and I will begin with the Assistant Deputy Commissioner, Chief Actuary, and that of our Data Science Division. One thing.
Commissioner, good morning. Before I ask Bishop to ask the question, I'd like to just highlight on our department here from actual area. We have 45 people and we have a few processes in the field. And so for this year, we have 2 health actually reviewing the verifying. Future has reviewed and verifying for the last several years, and now I share more also in the audience here. It's also the system is the reviewing process. Both of them have the actual credential. It's FSA, AA is the qualification, and also both of them have 105 years is actual experience. Our filing review process, having review of each filing and consideration of feedback from today's meeting, as referenced by Commissioner names, our actual area review also consider historical and projected experience, pharmacy rebates, rating rates, rating areas, state and federal mandates, company solvency, and other actual factors. To make sure the rate requests are not excessive, inadequate, or unfairly discriminated. Significantly, the CID's actual review of all requirement compliance all actual standard of practice from the data assumption to the transparency in communication. With that, I'm now going to introduce Bishop Devane to ask additional questions.
Thank you. I'm going to ask each of the companies some questions. I'm going to go one company, all my questions for each company before I move on to the second company and then the third company. Go in the same order that they chose for the presentations. So I guess we'll start with Anthem. Just to recap, you have 2 filings that you submitted for the 2024 rates. One is individual, one is small group. In the individual, you're asking for a 9.8% average increase, and for the small group, you're asking for a 14.9% average increase. Please explain any adjustments for COVID, including the costs for vaccines, testing, and treatment that you have priced for in this year's filings. And please note any difference for individual versus small group.
We did price in the impact of COVID actually that happened. You have on the rates, backing a reduction of roughly 1% of claims into the policy, and that translates to an improvement of roughly 0.5% trend. So the COVID impact actually reflected around 5%.
Okay, so just to summarize, in general, the rates came down for your impact of COVID because the costs are going down relative to the experience year.
That's right. Well, let me elaborate more on that. In our base experience that we used to develop the rates, which is 2022, it had more COVID impact in the base experience. And then when we projected out to 2024, we anticipate lower COVID costs. And actually, this is prior to the new information that I'm aware of, which is the new variants that are not up there right now. So when we compare the two costs in the base experience, the projected period, it is a reduction in COVID costs. That's what we're reflected in the pricing.
Thank you. Yeah, can you give us the impact on pricing for any state mandates that are not included in your 2022 base experience? Or any additional cost to be incurred due to the legislation passed in the most recent Connecticut session?
That is one of the keys that we did not reflect in our pricing. When we submit the rate filings, there are many views out there, finalized yet. And when we submit the rate filings first, we don't have a lot of time to look at it. So they are not reflected in our price.
Just for anyone who is not familiar, the rate filings were due on June 1st. The legislative session, I believe, ended June 7th, something like that. Okay. Due to the end of the federal health emergency, states are now going to be determining if the Medicaid population still qualifies for coverage. Can you please detail or explain how you price for this, if you did price for this for your 2024 rates and what the impact was?
So there are several areas that are an impact on rates. Due to the Medicaid redetermination, we will expect that the population would disqualify from the Medicaid program and potentially join the UKCA. And a bigger portion of that population actually would qualify for COVID Medicare. So we anticipate higher percentage of that population in COVID Medicare. So one of the keys, which is the CSR impacts that we have, that impacts because of we have more people qualify from 87 and 94 CSR. So we would expect some reduced utilization because of that. The second area, which is the benefits, where the CSR subsidies now is no longer funded by the federal program, so we have to reflect that in the silver plan. So there is a loading that we have due to anticipation of a higher COVID-connected population. That's two areas that we have.
Do you have a sense in general what the impact of all those would be, a net negative, I'm assuming, or positive to the rates?
So for the induced utilization, it's roughly 0.5%. Then on the silver loading, the net impact in total is roughly, I would say, 1.2, 1.3%.
Okay, thank you. And then just to follow up on the silver loading, what kind of data would you rely on for those kinds of assumptions? Was it your experience or industry?
So what we do is we look at 2022 to see what is the distribution of members that we have for 2022. And then we already have years to date data where the impact of the Medicaid unwind is not fully complete yet because we just see the data now. So we do see an increasing of the population that qualify for COVID Medicaid. And then we use that point of data to forecasted out in 2024, that's how we determine that.
And approximately like how much data was available to you as far as what we've seen so far in the unwinding?
So the latest data that we have, which is not our pricing. We see a jump from low 40 or something like that, get a jump all the way up to roughly, I would say 48, 47, 48% for the people on the CSR 87 and 90.
Yeah, and how much data, like do you have 1 month of data, do you have 3 months of data? Like how much data is out there?
These are only demographics that I'm talking about.
Okay. In terms of trend is a significant component of the rate changes for the 2024 rates. Just a quick summary of yours, for the individual filing, you're projecting a trend of 9.5% of total paid annual basis, and for small group, you're projecting 10%. Can you just give a feel for what you think are the largest drivers of that trend? For example, medical versus prescription, utilization versus unit cost, and where your concerns are for the future estimate?
In terms of service categories, I would definitely say look and hospital. In terms of utilization and unit cost, I definitely is one of the major factors.
And then can you just walk us through your process in determining the future trend and in terms of, you know, how much reliance do you use on historical experience versus addition of any factors that wouldn't be reflected in your past experience, but that you know are coming?
Definitely. So what we did was we looked at our historical allowable range. And then we need to remove some of the noises that we have in the data, like for example, COVID impacts that we had in 2020, and also the rebounds in 2021. We've also normalized our like engagement impacts. And then what we did was we run the regression to project it out into future years. And then we need to apply monthly impacts to get to our pricing trend assumption, which is what we really do, like you said, 9.5% is what we expect.
Okay, thank you. The most recent medical loss ratio report for the Affordable Care Act determined that your small group block was required to give back a rebate in the neighborhood of about $230,000. This means that the experience of the 3 years that was measured, 2019, 2020, and 21, did not meet the minimum benefits to premium ratio of 80%. Provide an explanation and tell us if you reflected this in 2024 pricing.
So the MOR calculation, it is a lagging indicator. Actually, it's a rolling 3 years average. So for the 2022 MOR calculation, it's the average of 2020, 2021, and 2022. If the MOR calculation is basically a safeguard, just in case if you miss on the assumption, and then the areas require to get a refund. And when we priced for 2020, actually, we did not expect COVID impacts. We didn't see that was coming. There was a significant deferred utilization for 2020. So it is part of the calculation for 2022. And then in 2021, when we filed our rates, actually we didn't anticipate a new carrier to enter into the market in mid of, I would say July of 2021. What that would change is to change the assumption that when we did our pricing, the risk adjustment. So some of these risks that we have in the when we did our pricing for 2020 and 2021, we didn't see that coming. And the safeguard of the MOR calculation actually is working, it's intended. to be, if you miss on the assumption or if you miss on the requirement, there is requirement.
Okay, one last question. Your profit and risk margin are significantly higher than the levels approved last year for both the individual and small group filings. Can you please explain that and why you would have a different assumption for small group versus individual?
So last year, when we filed our rates, we requested a similar kind of risk and contingency in our filings. The department requested carriers to lower the risk and contingency profit. So if you compare to last year, it's higher.
That's all the questions I had for AMPA. Paul or Winchin, did you want to do any follow-up? You want to wait till the end or? You just keep moving? Okay, so we'll move on. I guess the next company is Cigna. Just to recap, you have one filing before us. It's a small group filing. You were requesting an average of 23.0% increase. Can you just briefly go through the main components of the 23% increase by major category?
Absolutely. So there are three main pieces that I would call out. First being updates to our baseline assumptions, which I had called out in my initial testimony here this morning. Underlying the baseline assumptions update is inclusive of both the update to our experience period from 2021 up to 2022, as well as an update to our risk adjustment charge from 2021 to 2022. Beyond that, allowed trend is one of the major components of our rate increase for 2024, making up about 7%. And then the remaining piece, the third and final, would be changes that we've made for other administrative expenses, changes to comply with updated actuarial value requirements, where we could shift around benefit design to remain within the tower ranges. Happy to go into any further detail on any of those specific items, but those are the three I would call out.
And can you explain any adjustments your company made for COVID, including the cost for vaccines, testing, and treatment? If you did not make an adjustment, why? And in general, if you did, was it a net negative on the rates or a positive?
Yeah, so we made adjustments to our trend between 2022 and 2024 to account for the impact of COVID-19. That adjustment was a decrease to our trend between those specific experience period years. As part of that decrease, we expect, similar to what Anthem had called out, diminishing COVID costs over time between the kind of high deferred utilization return and spike in 2022, 2021, and what our go forward costs are projected to be. In terms of the total impact, we have about a 1% decrease, which is slightly different by both medical and pharmacy. And it results in a long-term kind of COVID cost assumption for testing, treatment, and vaccine cost in 2024 of about 0.5%.
Thank you. Can you provide the impact on pricing for any state mandates not included in your base experience and any additional cost to be incurred due to the legislation passed in the most recent Connecticut session?
Yeah, so the mandates that have passed at this point will likely have an adverse impact on claims costs. However, we did not explicitly include any adjustments within our go forward pricing to account for the mandates that either have been passed in prior years or the mandates that were passed right at the end of that legislative cycle when we had already submitted our filing. We will continue to monitor as these come through over the course of our experience period, incorporating the mandates actually being passed.
Thank you. And once again, trend is a significant component of your rate changes. Just to cap, you're on a total pay basis, your forward trend is about 10.1%. What do you see as the largest drivers of that trend, in terms of medical versus pharmacy, utilization costs versus, unit cost prices?
So our forward trend is 10.1%, which is inclusive of two specific components. The first being our actual allowed trend, the big part of that forward trend. The second component being our leveraging trend component, which is about 1.2% or so. As it relates to what we actually see as the main drivers of our go forward trend, the largest piece is pharmacy cost. Within there, at least the highest trend that we see is related to pharmacy cost. On the medical cost side, we do see trends around 7% or so on an annual basis as we go forward, with those being split by about 3% for unit cost, 4% for utilization. We are seeing, as I mentioned in previous commentary, a bit of an increase in our utilization, especially in our experience period that is driving our experience period trend. And then finally, I'll just end on, in terms of the pieces that we are seeing from kind of a future perspective that will potentially impact either our forward trend or future rate filings are related to an uptick in pharmacy utilization. As well as potential risk with some of the new drugs, especially GLP-1 drugs that will be entering the market. Ozempic is one that has been thrown around a few bit. So those are not explicitly included within our forward trend, but we do see risk there as they do come to market later this year.
And earlier you had talked about your affordability initiative, so I won't repeat that, but could you just state what impacts, roughly what the impact of that was on the pricing?
It was a decrease of approximately 3% on our experience allowed claims cost.
And then you, could you also explain, you had a change in morbidity due to market deterioration. Could you give us a little more detail on that?
Yeah, absolutely. So we look at one specific item for our morbidity adjustment that we apply to our experience. That specific item is a change in the market, so in Connecticut's morbidity as it moves through time. The specific measurement that we are making is looking at the decrease in the total number of lives in the small group market or member months on a year-over-year basis. And benchmarking that to analysis that we have done to look at the increase in morbidity as the number of lives decrease within the market. We're applying a 0.1% estimated morbidity increase for every 1% decrease in the market. Between 2020 and 2021, we saw about a 9% decrease in the total size of the small group Connecticut market. And therefore, which resulted in our assumption of a 0.91% annual morbidity increase as it relates to that market decrease. Over 2 years, which is what our experience period moves from 22 to 2024, resulted in about a 1.8% increase to our experience claims cost based on that market morbidity adjustment.
All right, thank you. And last question. Can you just walk us through your process of determining the future trend, including your reliance on historical trend experience versus addition of any factors that you know are coming down the road?
Yeah, absolutely. So as we look to determine our future trends, unit cost trends reflect our expectation of what future provider contracting will be in coming years, while utilization and mixed trend is developed from a national historical view that is then adjusted for any known changes within the market. As an example of some of those potential known changes on pharmacy utilization in particular, we reflect any kind of expected changes in future new drug approvals, as well as any generic drug entrants or changes to the mix within those specific items as it relates to projecting our future utilization trends.
And then as far as your historical view, did you rely entirely on the national? Do you only have 1 year of full Connecticut experience? Did you take Do you have any information on the Connecticut, or did you rely fully on the National Historical View?
For our utilization and mix component of our trend assumption, we rely solely on the historical national development of utilization and mix. On the unit cost assumption, we do use state-based specific information on both historical contracts, but also how we expect contracts with providers to play out in future years.
Okay, thank you. I'm done with my questions for Cigna. Next up will be Connecticut. Just to recap, you have 3 filings before us. They're all individual. One is fully on exchange. One is fully off exchange. The other company, Connecticut Insurance Company Incorporated, is a mix of both on and off exchange. You're asking for an average increase ranges between those 3 filings of 12.7% to 17.5%. Can you explain any adjustments for COVID, including the cost for vaccines, testing, and treatment, and detail any differences by on or off exchange?
So our expectation for COVID in 2024 is a reduction of roughly 0.7%. We removed at the request of the department roughly 2.8% in COVID from the baseline period and added the additional 2.1% in the projection period. This results in a net negative 0.7 percentage point due to COVID expected.
And that's for all your filings, the net negative?
Correct.
And then can you please, consistent with the question for Anthem, explaining changes to your morbidity and the rates due to the Medicare redetermination or unwinding that was described earlier?
Sure. So with the upcoming Medicaid redetermination unwinding, we are expecting some additional members to be part of our Medicare population. We expect that these members will look very similar to members that are currently part of the Covered Connecticut program. And we looked at the experience of that program. Our members are getting premium and cost sharing. Their premiums and cost sharing relief. We do expect that the Medicaid population, we expect to enter this market, will look similar to those members. We assumed roughly a 0.6 percentage point increase in overall claims as a result of these additional members. We did take a look at a weighted average of the Covered Connecticut population and how that compares to the rest of our block. And given the membership we expect to enroll, assume that increase would be a result of those members.
Okay, thank you. And then can you provide the impact on pricing for any state mandates that are not included in your base experience and any additional costs due to legislation passed in the most recent Connecticut session?
We did include one adjustment as a result of mandates, particularly for the requirement to cover preventive breast and ovarian cancer screenings. We assumed a factor of 1.0025, roughly 0.2 percentage point increase as a result of that mandate. We did not include any additional factor for any other demands.
All right, and that factor, I know, was consistent with what you used last year. Did you have any recent actual experience that I would say that was adequate or was inadequate relative to the assumption used last year?
At the time of submitting our rate filing, I don't really get any additional data that would indicate that factor was not recently.
Okay, and then also the most recent medical loss ratio report for the Affordable Care Act determined one of your filings, it was the on-off exchange combination, was required to give back. And in your case, it was approximately $1 million and $1.5 million back. And that would mean that your experience over the rolling 3 years that was looked at, 2019 to 2021, did not meet the minimum benefit to premium ratio of 80%. Can you provide an explanation and tell us if this was reflected in your 2024 pricing?
Yeah, so the company you're referring to is Connecticut Insurance Company. The population at the time of that calculation was substantially different than our current population. We put products on exchange beginning January 1st, 2022. Since that has occurred, we have seen a pretty substantial increase in claim costs. Also, that earlier period included 2020, where we did see some reduced utilization due to COVID. Given the population that's enrolled in 2022 and 2023, we believe that experience is much more reflective of what we expect going forward, and therefore did not consider that in our rebate.
Okay, also your 2024 filing included a large increase in administrative costs. Can you just give us a feel for what's driving that increase? And this was across all three companies.
Yeah, so we did take a look at our administrative costs and how those have changed over time. There are some internal changes and allocations that have been reviewed to ensure that we have the appropriate administrative expenses aligned to these products. That is a driver of ensuring that we have the appropriate administrative expenses for each of these products. Additionally, there is an increase of roughly 0.2% with the increased exchange fee as well. That is driving those administrative expenses.
Okay, and then just on trend, obviously the other company's trend is an important piece. In summary, you're asking for the three filings range of 11.2 to 11.5%. What do you see as the largest drivers of this trend? You know, medical versus pharmacy utilization versus unit cost.
Yeah, I think consistent with what you've heard from other carriers as well. Pharmacy costs in particular have going up dramatically. Brand specialty drugs on a unit cost basis have driven costs. We're assuming something just north of probably 20% year over year in terms of increased pharmacy costs. We do have other increased costs on the outpatient physician side that are pushing trend higher, but pharmacy is the biggest problem.
And that concludes my questions. Paul, or one change wants to comment.
Thank you.
Commissioner.
I have a couple of quick questions on the direct demographic from Sigmund Hospital, and based on a couple of items you mentioned. One was on the future plan, and that seemed to incorporate future contract. And I'm just wondering, did you incorporate in that plan projection the cost for a benchmark, or you assuming that the budget is not provided at that benchmark?
We've assumed our best estimate expectation of what we assumed the contract with. There's not an explicit assumption of the hospital benchmark incorporated within the cost contracting in our current.
And can you give us an approximate projection for the assumption that you make?
The unit cost trend for 2024 to 2025 sits right around 3.5% to 4%, which feeds into a total medical trend of 7.6% for the year. Our pharmacy trend is actually the much larger component of our overall future trend, and is currently sitting around 13% for 2024 to 2025 specifically.
That actually leads me to my second question. As you spoke, you mentioned the pharmacy costs that you mentioned, GLP-1 agonists, for example. Are pharmacy costs being driven by general inflation, by specific drugs? What are the cost drivers?
Yeah, so pharmacy costs are being driven both by utilization component, which we've seen an uptick in actual utilization, as well as the mixed components in terms of new entrants into the market with higher costs. But also the actual unit cost, we are seeing significant impacts in the GLP-1 space, as well as in the inflammatory condition space for specialty drugs specifically. Both of those pieces are the largest driver of what we are seeing in terms of high pharmacy spend on a year-over-year basis, especially there.
Thank you. Let me turn it over to the Deputy Commissioner and the Director of Public Health Division, Paul Lombardo. Paul.
Thanks, Commissioner. Good morning, everybody. Two real quick questions for the group. One, Brandon, you mentioned 64 we're up to with regard to state-specific mandates. Can each one of your companies here provide us with what the total percentage of your premium that you're projecting in 2024 is going to make up of those 64 benefit mandates? And on a PMPM basis, that would be great. The second comment or question I have is the majority of many of your company's business, I think, aside from Connecticut, is self-funded large employer business. Do you have the same networks for your self-funded employer plans and same provider reimbursement that you have for the individual and small group market? And I think I'll start with Ian first. Thank you.
Yeah, I'll speak to the second question first, then I'll turn it over to answer the first question. But yeah, for our level funded product and our ACA based product in the small group market, we do have the exact same networks available. So it's either an HMO pathway network or a PPO, and the reimbursement will be consistent with both.
And in your self-funded large employer market, would the networks and the reimbursement be identical?
Same there as well, I guess.
And what was your question?
The 64 benefit mandates that Brandon mentioned, do you have an idea of what percentage of premium?
Yeah,
It
we
is.
don't have that information. I know that when Brandon speak to all the mandates, actually it's going back to like a long history of the mandate was passed. So we didn't go back and reevaluate it about what the impact from those mandates are. It is included now in here.
Yes, I guess the question would be is you know what the benefit mandates are, can you tease those out of your claims and give us an estimate of what those mandates are worth today in your premium?
Yeah, we can look through that. As of right now, I don't have that.
Understood, thank you. Sigmund?
I'm gonna give you a very similar answer to some benefit mandate pieces. You can certainly take that away. And try to tease out what within our claims costs for 2022, especially, is related to benefit mandates that have been passed directly. On the second question related to provider networks and reimbursement structure, Sigma plus Oscar utilizing the Open Access Plus network within Connecticut with the same provider reimbursement structure as what we have in our large group self-insured plans that exist within the state today. Network structure is the exact same, got the same providers and physicians that are within the network specifically, and all of the reimbursements are equivalent. So
Thank you for that. In Connecticut?
I'll similarly provide you a comments on the mandates. We did, as I mentioned, have an explicit adjustment for the rest of their cancer screening. Other mandates that have been in place historically that is knowable, we can take that away, but I don't have that information from it.
And Paul, I just wanted to comment that we do have self-insured products on our portfolio, and they're high quality products, just so people understand.
Yeah, I didn't mean to say that you didn't offer them, Mark. I think the two companies to your left have a higher percentage of their business that's self-funded. Are your networks similar and provider reimbursement similar in your level funded and self-funded plans that you versus what you offer in the individual market?
Yes, they are.
Thank you.
Thank you to all presenters here. We view this as a crucial component of the process for companies to clarify the rationales supporting the request for the rate increase of the year. We're gonna take a short break, and when we return, we will have, as part of the program, first Attorney General, then the Executive Director of the Office of Health Strategy, then the state's healthcare advocate, and the chairs and ranking members of the Insurance and Real Estate Committee. So this break should be 10 minutes, let's go. Be here.
Yeah. Where do you, from? Just your general citizen?
Does she have anything else? Are you really? I mean, this is like a lot of people have to pay.
No. You know. Change my chair. Yeah.
Yeah.
Yeah. No, it's still. Okay. That's not enough. Oh, I.
Gotcha. Well, it is. So. Okay. That's fine.
Yeah.
Please take your seats, please take your seat, we begin the meeting in 1 minute.
So how you met? You can smile.
Thank you all for being here. We will now resume the meeting, and to begin the next part of the program, I would like to invite Attorney General William Tom. No,
Thank you, Commissioner, and the department. Thank you for the opportunity to be heard today on behalf of consumers and insureds here in Connecticut. As you know, Commissioner, I've called for these proceedings to proceed as a more fulsome administrative hearing under the Uniform Administrative Procedures Act. I will request again that we convene such a hearing, so I appreciate again that you're having us here this morning. We're here this morning because Cigna, Anthem, and Connecticut want even more money. These are three of the biggest and most profitable health insurance companies. Two of them, maybe two of the biggest and most profitable in this country. And now they want rate increases that will take millions more from Connecticut families. If these increases are approved, we know two things for sure. We know that these huge companies and their executives, and that's critical. These two huge companies and their executives will make a lot more money. We also know that these increases will punish and hurt Connecticut families. What we don't know, after several hours this morning, we don't know why they need more money. Nowhere in their rate application do they say they need more money because they'll make healthcare better. I don't see them saying that they will deliver better quality care, better service, more access to care and treatment. These insurers request and receive increases year after year, but no one has said to me, you know what? I'm willing to pay those increases because I'm getting more coverage, access to more treatment and doctors, claims are getting approved quicker, customer service is so much better. No one is saying that, at least not to me. And that's one big reason why the department must reject these increases, because Cigna, Anthem, and Connecticut have not answered a basic question. Why do they need more money? And why do they need so much more money? And pursuant to Connecticut law, Commissioner, you know that in order for these rates to be approved, the department must determine that these requested rates are not excessive, inadequate, or unfairly discriminatory. That's the legal duty the department will discharge today. Cigna, Anthem, and Connecticut have failed to justify rates that are excessive on their face and unsupported by the facts asserted in their applications. For example, if you want to see why these rates are excessive, you can start by looking at trend. We've talked a lot about trend this morning. Trend is the rate at which insurers project that healthcare costs will increase. It consists of two components, unit cost and utilization. It's a forecast, it's a projection. and it's the basic underpinning of these requested rate increases. Objective data tells us that healthcare cost trend is no more than 5.6%. Let's consult the objective data that the insurance industry itself uses. Millman, which is a large actuarial firm, which the insurers rely on themselves, produces the Millman Medical Index, which calculates the actual medical trend in recent years and estimates trend for the current year. In its 2023 index, Milliman reports that annual healthcare trend since 2021 has been 4.8% and projects trend in 2023 of 5.6%. The Connecticut Cost Growth Benchmark, which is produced by the Office of Health Strategy, projects for 2024 a trend of 2.9%. And the state employee health plan, managed by one of the insurers here today, Anthem, reported a medical trend of 3.7% for the period April 2022 to March 2023. So you've heard these numbers: 4.8%, 5.6%, 2.9%, 3.7%. So with those numbers, why? Why are the insurers showing up here today, Cigna, Anthem, Connecticut, projecting trend far in excess of those numbers? Why? Why is Cigna, for its small group filing, inexplicably using two different trends of 8.3% and 7.4% in different parts of their application? Cigna assumes identical trends for inpatient hospital charges, outpatient hospital charges, doctors and other professional charges, and charges for other medical services, although the change in cost and utilization of these various components is inherently different and varies from charge to charge. Anthem, individual and small group, assumed a trend of 9.5% for individual and 10% for small group annually, which applies for 2 years, resulting in a 19.96% and 21.42% trend for the relevant 24-month period. Anthem never shows in its documents how it arrives at these inflated, excessively high 9.5 and 10% trends that far exceed Milliman, far exceed the Connecticut Cost Growth Benchmark, far exceed their own trend in the state employee health plan, which again is at 3.7%. Connecticut assumes an annual trend factor of 11.2% over 2 years, 23.8%, the highest trend factor used by any carrier in its 2024 rate filing. Now we've heard a little bit about Connecticut, and it points to an increase in morbidity due to the Medicaid unwinding process, in which they claim that states are redetermining eligibility for Medicaid, and they project that that means that people will effectively lose their Medicaid coverage, that they'll go back in the pool, and then Connecticut makes a huge leap and assumes that this Medicaid unwinding will result in sicker patients entering Connecticut's risk pool. But Anthem, on the other hand, who's also here today, doesn't assume that that will happen, and they make no change to their morbidity factor. Connecticut also increases its rate by an additional 0.8%, a provision for adverse events due to historic changes in the marketplace that have increased costs and anticipate will increase costs in the future. Although there's no explanation whatsoever about these historic changes in the marketplace. Trend is a forecast. It's a forecast of higher costs, and a forecast based on higher unjustified trend means higher costs and rates guaranteed. It becomes a self-fulfilling prophecy. You know, if we accept that there's a higher trend, the higher trend assumes that healthcare providers will increase their charges in excess of inflation and medical inflation. So providers know that the department will assume and approve the higher trend, then providers will go ahead and increase their charges in line with their higher trend.
So if you set the number up here, it makes perfect sense that providers will raise their prices to meet that trend. But what I asked the department to do today is to push back on that and reject these unjustified trends. If the department does not assume that providers would increase their charges in excess of inflation, if it does not accept these high projected unjustified trends, then these insurers would have an incentive to go back and use their leverage to negotiate lower reimbursement rates. This is just one reason why these rates are excessive and unjustified and must be rejected. I am now going to yield the remainder of my time to Assistant Attorney General Tom Ryan, who leads our offices and our state's efforts to fight for consumers and insurers in the health insurance market. Tom will address additional questions and concerns of future meetings.
Thank you, Attorney General. Thank you, Commissioner Mays, and thank you all for being here. As the Attorney General mentioned, and I will try to direct questions to each carrier individually. He mentioned that Medicare has what it calls provisions for adverse events, and it put a 0.8% adjustment in place for that, but it doesn't really define what the adverse events are, and that. So what is that about Medicare? What are those adverse events, and are they speculative, or do you actually have something in mind that you would identify to the division?
So the provision for adverse events included in our rate filing is aiming to account for changes in the marketplace that happen after our rates are filed. We have no ability to influence our rates for 2024 after rates become filed. In the past, we have seen things such as the COVID-19 pandemic, emerging federal and state mandates, this Medicaid unwinding as well, which occur after our rates become final, that we are required to account for and have no ability to influence rates in that calendar year to account for this. There are also actuarial standards of practice that refer to provisions for adverse events. They state that the actuary should consider whether there are significant risks and uncertainties that could result in the future paid amounts being materially greater than those provided for the liabilities. Additionally, in the actuarial standard of practice, it states that the provision should result in liabilities that in the actuary's professional judgment are sufficient to cover obligations under moderately adverse conditions. We believe that this inclusion of the 0.8% is consistent and meets the standards set forth in the actuarial standard of practice.
Can you explain why yours is the only plan that has the provision?
I can't speak to other plans for filings.
Turning to your administrative costs, Medicare has the highest administrative cost of any of the carriers at $93.40 per member per month. What are the components of that administrative cost? Why has it increased since last year and over the years? And we are not seeing in the filing that breakdown. Can you explain that to us?
Yeah, so let me address that really quickly, and then Brandon step in if there's information to say. You know, we are not a national carrier, so our administrative costs are a bit higher than some of our competitors. That's part because we don't have their economies of scale. We also have a local service model. So you know, we actually have two offices, one in Manchester and one in Farmington, where people can actually walk in and have solutions if they have questions about their coverage. I think we're the only carrier that has that. Those are brick and mortar facilities, so that increases our admin costs. We also have the call service center where people, we have a Connecticut person, a member can actually call a Connecticut neighbor, it could be neighbors, serving our folks. So, you know, our model is a little more expensive, but you know, that's how we distinguish ourselves from some of our competitors. So with that, you know, I don't know if Brandon has anything else you want to say.
Would you be able to provide that Commissioner with a complete breakdown by percentage of that administrative cost and the elements of the administrative cost?
I don't have that in front of me. That's not constantly why something that is available.
You have discussed, I think, in response to the department, the Medicaid unwinding impact. Your Medicaid unwinding is greater than your competitor Anthem in the same market, which is the exchange market. Can you explain why you expect your population to be at higher risk as a result of that impact?
So we took a look at our existing underlying experience for the covered Connecticut population. As we mentioned previously, this is a program that assists members on premium and cost sharing. We do expect that with Medicaid, members who will enroll in Medicare will utilize services in a similar manner to those members that we have today. And so we looked at our actual data and our actual experience and used that as the guideline for setting that subject.
You, in your filing, you indicate that you have foregone using the 2020 experience in your trend calculation. Can you explain to us why you did so?
Yeah, so we look at a number of different data points when setting trend and trying to project what we expect in 2024. 2020 was a difficult year, and we did see utilization go down. We also saw in 2021 utilization return even beyond what we expected. As a result, we look at a number of different data points. We're looking at recent data, we're looking at data from pre-pandemic as well, and really trying to normalize for those years that were abnormally impacted by the pandemic. So we took a look at that as we were seeing the trend.
So is it fair to say that 2020 was an aberration, and then the subsequent years, pent-up demand for also sort of skewing too high? Is that fair to say?
That's how we view 2020 and 2020 from the trend.
Okay, thank you. So I think with that, I'm going to segue to Anthem because, as you heard, Connecticut decided that 2020 was not a good year to use its credit calculation. Why did you use 2020 in your credit calculation, and wouldn't it be better if Connecticut did use the more normalized year?
I do agree with Brandon about the noise in the data because of the COVID year. But what we did was we tried to normalize out those noises before we use the data. And that is the key. I don't think that there normalize the impact of COVID out of the experience data. Versus the anthem before we use it, we have to normalize.
And did you, is there somewhere in the filing where you show formulaically how you normalize?
Earlier, I did indicate on how we factor in the COVID impact. But earlier, we actually have a rate reduction due to COVID because of in the base experience for 2022, the cost of COVID are much higher than the projection years with 2024 that we have. So we try to make sure that whenever we use the data or something like that, we appropriately reflecting the impacts of COVID.
But is that actually shown in the file? Is it what are you, is your adjustment actually numerically shown?
That is going from 2022 to 2024. But if you're talking about going from 2020 to 2021, that is a huge kind of COVID impacts. Like for example, you have a deferred utilization in 2020. And then there is a rebound of utilization in 2021, and as you saw earlier, the 18% trend that we saw in the earlier presentation, it's actually, I don't believe that number is normalized out or remove the impact of COVID. If you remove the impact of COVID, you would see a much normal level of trend.
Okay, but that's actually demonstrated in the filing.
we do say now we respond that we normalize how some of the process.
So isn't that more of a statement? Probably normalize it. I mean, I think it's important to show the part of the normalize.
Right, so like I said, in 2020, it is, there was a big deferred utilization.
Yeah.
And then there is a big rebound, so we have to estimate what are those impacts and not remove from the experience, and that's what we did.
Okay, well, we would ask that you actually provide the department with very specific information on how you utilize your data. So, Anthem, you refer to other benefit expenses in your rates. And specifically, you make reference to settlement. But you don't explain what settlements you're talking about. Are those legal settlements, and are they settlements that happen in the Connecticut market, whether you're related to these particular plans, and what, you know?
So earlier you heard Brandon talk about the value-based programs that we have in Connecticut. So depending on how the provider meet the requirement for the value-based kind of program, and then we have to pay some of that out. On top of that, there was some surcharge that we have to pay for services that provided by your hospital. So that claims benefit expense are included.
All of that's happening in the Connecticut market, or it's not, is it regional, or is it national, or is
This
that
is local.
it's only related to these policies?
Exactly.
Okay, can you provide the insurance department with an actual specific breakdown of those settlements and payments? So that-
We actually respond in writing with the department on that question.
Okay, so you have provided a specific.
Yes, we did respond to the questions that were followed.
Okay, thank you. I guess, just in closing, the commissioner mentioned something which is very true, and that's and you all recognize that these unit costs, the hospital costs are a huge driver in the expenses that you're all facing. In 1994, Connecticut became the last state to deregulate hospital pricing. And prior to 1994, it had a formula in other states, which was a cost-based formula that allowed hospitals to have a reasonable profit margin. So the commissioner has asked you guys, why aren't you negotiating harder? Why aren't you delivering for us? In 1994, the Connecticut legislature in Connecticut assumed that managed care would come in and replace that formula and keep hospital costs low. Now, there are a lot of factors that relate to hospital costs, but when you negotiate with these hospitals, do you actually line item with them based on cost? Do you actually get down to what Harvard Hospital, what are your costs to provide this service? And then go build off of that as a reference point, or are you using things like the charge method, which isn't really based on any cost factor when you negotiate? So I think, again, citizens of this state are very concerned that you negotiate hard to hold down their costs. That historically hasn't happened since the deregulation. Can you tell us whether you actually use cost as a negotiating starting point on a line item basis with hospitals? Because I think that's kind of what we need.
Yeah, I guess I'll go first. From an Anthem perspective, and I'm not on the provider side, so I'm not very, entrenched within the hospital negotiation process. But from my standpoint, where I stand on the sales side, and obviously having, an ear to the ground, these hospital negotiations can be extremely difficult. We are, again, as I mentioned earlier in my, earlier testimony, we are driving towards value-based care. I think that's where we're going to find a significant amount of change in driving down that cost overall. If you guys recall, not so long ago, we're going back a few years now, but we did remove part of Harvard Healthcare. We did not come to an agreement with Harvard Healthcare based on difficult negotiations that we had to get to in order to drive costs down. So we are fully committed to ensuring that the overall cost of care comes down through value-based arrangements, and that's what we are committed to driving in the future.
Commissioner, we'd ask the other two insurers answer the question.
Hi, this is, yeah, can you hear me okay, Zach? So respectfully, similar to response from Anthem, we're not necessarily prepared to go deep on this topic today. Perfectly willing to take it away and bring it back into a forum where we can. But we do promote and drive a volume to value type mentality. And we are always looking for ways to drive costs down when negotiating with our provider partners, hoping to continue to allow that lever that is so important to be leveraged to its best, to the best of our ability. So not prepared to go any deeper today. I am on the sales side, but happy to take it away and come back to you with a firmer answer. Thank you.
I can tell you for Connecticut, the direct answer is I'm not sure. I know that our folks who are negotiating these contracts, we do use the benchmarks. We do use all the tools we can. We try and find all the data we can about a hospital and the price before we go into the negotiation. But sometimes we can't get data that we might like. So I can get more specific with you and provide you with that information. But I do know we scour the waterfront to get the information we can, to go in there and negotiate as hard as we can on behalf of.
Just one last thing. Would you agree, though, that excessive costs drive excessive rates?
So I do agree that right now, the cost of our rates, our rates are because of the inputs. It's the hospital costs, and they're getting bigger. And the problem, it's the pharmacy costs, and they have tremendous patent power. So at the end of the day, those increases are causing our rates to go up.
Commissioner, if I may just close by saying, I think you heard the answer here. It was a simple question. You negotiate unit costs line by line, service by service, and the answer is no. You don't. I frankly, I'm shocked that that's the answer. And if the answer is, well, we're not sure, we don't know, that's even more shocking. That's why these increases must be rejected. This is wholly unsatisfactory, Commissioner. And the insurers must be made and incentivized to negotiate costs, negotiate it down, to hold providers accountable and to save money and provide better care and better service for the people of the state. Thank you, Commissioner.
Thank you, Attorney General Tom, Assistant Attorney General Fine. Next, we will turn it over to the Executive Director of the Office of Health Strategy and Development, Chief Health Policy Advisor, Dr. Deirdre Gilbert.
Thank you, Commissioner. Thank you, Mr. Attorney General. Actually, the question by the chair along a very similar line to those who just heard. I mentioned in my earlier remarks about the benchmark that national data, there's a trend now to towards transparency in hospital costs. And so whether you look at the SAGE transparency website or look at the National Hospital Cost Tool, we know that there's a lot of variation between states and within states and what you all are paying hospitals for the same service. And as I mentioned, we have within Connecticut almost a twofold variation between the lowest priced hospital and the highest priced hospital in the state. And so I wondered if you could talk about why we see that variation. I'm sure that you know roughly what, who are the highest paid providers. Can you tell us a little bit more about why we see that type of variation?
Yeah, I think I touched on this earlier. I think the provider consolidation has had a significant impact on that. As we see more hospital consolidation and the bigger payers, the bigger players here, start to buy out some of the smaller hospitals, that's had a massive impact on our negotiation ability. At the same time, I mentioned this earlier as well, we do continue to fight that fight, obviously try to drive the overall cost of care down. The negotiations that we have with these hospital providers, as I mentioned, are extremely difficult. But I think we are driving towards that value-based care in order to bring those costs down.
Did you mention, and I apologize if I forgot, but did you mention how much of an adjustment to these filings you have made to account for some of the value-based payment strategies that you articulated? In other words, your requests are X% lower because of those redeeming programs?
It's already reflected in our base experience, because over time, whatever the value-based program that we put in place, that's safe, eventually we will get to the experience. So it's already reflected in the base experience. We do not make any explicit adjustment to project outward to the.
I see. So there are no new programs that you're implementing in 2024 that you accounted for in these filings to bring down price or cost?
I'm not sure if I'm aware if there are any new programs that we have, like Brendan mentioned earlier. If there are new programs and if we expand those programs, we definitely reflect that into our rates. But like I said, these programs have been implemented and I believe it's already reflected in our rates.
Thank you. My second question is about drug costs, because all of you identified, as we have seen in our data strategy, that hospital costs, both inpatient and outpatient, and pharmacy are the primary drivers of our cost. So at our benchmark hearing in June, we heard from one drug manufacturer that's that they are providing rebates on drug costs, and but they were unable to explain to us how those rebates are actually actually affecting either what people pay when they pick up their medications or how they're driving down the premiums. So could you talk about how the rebates provided by the drug manufacturers are impacting these rate filings and how they're impacting consumers when they go to protect their pharmacy?
By law in Connecticut, we are required to reflect the full drug rebates that we receive into our rates. So in our rates development, we actually have a line item where we reflect the full amount of the drug rebates.
Yeah, and I just add specific to the consumer experience, we're doing our best to educate our members as to what their best alternative is. So it may be a rebate card that they get from their drug manufacturer. It may be switching to an alternative generic lower cost medication. That's where we have a lot of our clinical programs that come into play to drive that change.
Thank you. So what is the differential between the rate filings that you did submit and those you would have submitted if you had not accounted for the rebate? In other words, how much are the premiums on the lower because of that rebate?
For individual, I believe it's around $45 PMPM on the small. Let me restate my response earlier. For individual, the impact is roughly $45 PMPM, and then on the small food side, it's around $48 or $49.
So moving to, can you tell us how to account for the variation in hospital payment within your plan? Why there's almost a twofold difference in what insurers are paying hospitals in Connecticut?
And speak to the underlying data that was used by the Office of Health Strategy to look at specifically where that gap is coming from as it relates to Cigna's own costs and experience with provider systems within the state of Connecticut. Very similar to both Medicare as well as Anthem that I've mentioned previously. We continue to negotiate on behalf of our customers and drive as affordable costs as possible within the marketplace. As we think about some of those specific hospital systems, providers, physicians that exist within Connecticut specifically. There are certainly different specialties, there are different places within Connecticut from a geographic cost perspective that could drive differences in the percent of Medicare that we see as a result of the negotiations that we have brought in the past with each of those specific systems. Kristen, do you have anything to add to that specifically?
Yeah, thanks, Zach. I appreciate the question, Dr. Gifford. I think the other consideration you have to think about is the underlying cost of healthcare, and specifically as it relates to the setting, the location of care, and then obviously quality. I think it's going to be important for Cigna and providers to continue to engage in all these key areas as the evolution of healthcare continues. We talked a little bit about innovation. We talked about technology, not just technology on the in carrier side, but as importantly, technology on the hospital side. We're going to have to collaborate and find ways to incentivize the kind of behavior that you've described. And I would be remiss if I didn't say that I think Cigna's had a long-standing history of provider collaboration, and we are committed to continuing to deepen that engagement with providers for all the critical reasons that you outlined in your question.
Thank you. And just to be clear, I wasn't referencing OHS data in that question. I was referencing data that's available on the National Hospital Cost Tool and also the Stage Transparency website. I will just, as I mentioned earlier, say that it's very difficult to see any relationship between quality ratings and hospital care and hospital prices. And there's also no clear geographic distribution indication between the highest cost hospitals and the lowest. High cost hospitals tend to be spread across the state, lower cost hospitals tend to be spread across the state, even within a single system. So I would encourage you, as you are thinking about your negotiations, to familiarize yourself with some of that data, because I do think, as you indicated, we don't see an adequate explanation for that lack of information. And finally, I'll ask you, Medicare, how do you account for that level of cost variation within our own state?
So there's probably several factors. I mean, one, there are some hospital systems that have perceived higher quality than others, whether that's true or not. They prefer the brand. There are some hospital systems that can perform services that the other hospitals can't. And some that simply is market power in particular hospital. So those are some of the reasons. I'm ready to everything.
Thank you. And I forgot to ask you about the consumer experience at the checkout counter in pharmacy. How are the rebates that your company receives reflected when a person goes to pick up their prescription?
Thanks for the question. So first of all, 100% of the rebates that we receive from pharmaceutical manufacturers receive also customers get passed on for lower overall drug costs for the overall product. Number two, we purposely built in co-pays into all of our plan design so that the members cost share regardless of the drug that they selected the same. So you can give them $1, paying $40 copay. Yeah, you can pay that same copay amount regardless of the drug you choose. The rebate then comes on the back end to lower the overall health planning cost after the member has received their drug. Again, therefore, they're not necessarily influenced or otherwise changing their opinion based on the back end rebate. And then lastly, Cigna Plus Oscar allows any and all coupon value programs and manufacturer coupons that a individual might want to take advantage of to in fact accumulate to out-of-pocket deductibles as part of the health plan that the Connecticut requirement. So the full value of that coupon then gets accumulated, which is to the benefit of the customer.
So is it possible that a person who hasn't yet met their annual deductible and on an expensive medication could pay more at the counter for that drug than you would actually pay post rebate?
Situation you're describing would be they would pay the full amount every day on the back end with over the overall payment.
A consumer who's on an expensive drug picks up the drug at the pharmacy counter, hasn't yet met their annual deductible, so they pay that's high cost for the drug. You receive the rebate from the back, and as you say, is it possible that the consumer paid more for the drug than you did?
I would say it's possible. It's not particularly common due to the fact that most of our drug purchases go through copay based benefit, so it's flat rate no matter what. And then we shy away from, because they're not very popular, having separate pharmacy deductibles. We tend to see that customers prefer not to have that, and so it's usually a rare occurrence that a customer would pay more than what we would pay.
Thank you. And I hear, did you want to answer that question?
So I'll answer the question first on rebates, how they're similarly in our pricing and projected plan expense. We look at the most drug costs. We also look at all rebates and the net costs after the rebates effectively becomes our pharmacy expense projection, which then in turn is also the rate. So to the full extent we're receiving any rebates on drugs, we are building that into rates as reductions for the member. And then the situation that you're describing as well, again, I think rare occurrence where that could be the case. I think in aggregate, when we look at everything, we are definitively reducing our projected pharmacy expense and lowering our rates.
Thank you.
Thank you, Dr. Gifford. And now we will turn it over to the state's healthcare advocate, Ted Dooley.
Thank you, Mr. Commissioner, and thank you to all the chairs for being here today. My name is Ted Dooley, just for those who don't know, I also the healthcare advocate, state government, to help folks who are fighting to get their health coverage, be it public coverage, Medicare, Medicaid, or private coverage, so if you have a claim denied, something of that nature, and we want free expert representation from team attorneys, paralegals, nurses, and others. Remember to do the vaccine. So quick question, on the small group filing first for stigma. And I think that would be mean. I understand that you incorporated profit margin 3%, is that correct?
It is a profit and risk margin, so both the risk load as well as the profit is at 3% under the 2024 filing. Yes.
Okay, thank you. For Anthem, I believe that you use, so you use 3% and you use 6%, is that correct? 6 versus 3%, Mr. Commissioner. To move on to the needed issue here in terms of follow the dollars, which I like to do, as folks know, the premium dollars under the Affordable Care Act law, the carriers can change 15 or 20% depending on the type of plan. So that means that 85 or 80% of the dollars go elsewhere. And we've talked a lot about that. We've talked about pharmaceuticals and we talked about hospitals. And we've talked in general terms. I want to get a little bit more concrete. We'll just go down the line, start at the Anthem. Can you identify the highest cost hospital in Connecticut and identify the lowest cost hospital system in Connecticut?
I personally don't have that information available. It's a bit of checking.
Okay. Second.
I also don't have that information. Okay.
Okay. Connecticut.
Yeah, so, we could make some guesses, but talking about that, probably wouldn't be fair if we get it wrong. So, we have perceptions and it depends upon which service we're talking about. But, we can provide some of that information to get that,
Okay, well, my suggestion this year, as it has been for a number of years, is that we should follow where the money goes and where the premium dollar goes. We're here to talk about premiums and where the dollar goes to the hospitals. You folks are here in some ways quite unfairly as a stalking horse for the hospitals. I believe that the hospitals should be here. We should identify which ones are potentially the most trending and should be here every year. What do you think about that, Mr. Bishop?
Yeah, I kind of stated this a little bit earlier. I think for the benefit of all consumers here in Connecticut, to bring everyone to the table, anyone that has any skin in the game here would be beneficial for us all.
Having a comprehensive conversation similar to the one that we had back in the spring, where both representatives from provider systems within the state of Connecticut, payers within the state of Connecticut, as well as pharmacy manufacturers and PBMs would certainly continue to provide value to customers in the state of Connecticut specifically.
What are you using?
Yeah, we agree that there should be more hearings like this, if not this one, others, where the hospital systems and other providers have to take accountability for their pricing to us.
So I'll note that my office in a written request did ask for details on the contracts. I think that, Mr. Commissioner, is really needed to get a full view of whether or not the rates are reflective, inadequate or unfairly discriminatory. So once again, raise that. I also would urge the carriers in future years to bring, if each of you has emerged, and I understand that's fine, in terms of negotiations and in terms of identifying the highest cost hospitals. There are folks in your organization who know that information, and I would urge them to come forward next year and be part of the year. I think that's really appropriate. I want to, we've talked a lot about affordability. That's an outcome we all want to see. I think universally in this room, probably everybody who's watching on TV wants to see healthcare costs go down. And with that in mind, I have a question about, and I've asked this in written submissions in prior years, and I think again this year. When you determine your executive compensation, particularly your staff compensation in general, is affordability a consideration when there's progress on, we've talked about unit costs, progress on unit costs of consideration to the best of your knowledge. And again, you might not have the right folks here, but starting with nothing. The executive and or staff compensation is the affordability to the consumer and the all-in cost to the consumer. Controlling that or ultimately getting that down is that consideration for your staff compensation.
So when we develop our rates, we have to follow the standard actuarial practice, and we also have to provide the law. So when we develop our rates, we start out with the 2022 experience, and then we have to have reasonable assumptions to go along with the experience before we get there. And it is subject to the Connecticut Insurance Department.
Would signatory comment?
So as part of our executive and staff compensation specifically, is the affordability pieces driven as part of it? Is that what your question is?
Yes.
Unfortunately, I can't speak specifically to the actual executive and staff compensation. That information is proprietary and confidential and part of what Cigna determines internally. So, Kristen, anything to add to that specifically?
No, nothing to add, Zach. Thank you.
Nick?
So I can't answer that completely, but I can say, like, the negotiating team, if they do a good job and keep prices down and get the rates down, there are certain benchmarks that they may be compensated better than if they don't get the lower rates of hospitals. So yeah, there are some components there, and I can't go through them all, but yes, there are some.
Before I leave the topic out, just mention if there are any board members in the hospitals in Connecticut listening, I would ask the same question to that. The executive compensation committees, which I think probably largely populated by board members, do have an opportunity to ask for pay for performance. I don't know what factors the hospitals use to create their executive compensation structures. But if they don't include metrics, which I'm sure that the OCL strategy would be happy to help you develop, and my office would be happy to be involved too. You don't have the metric of what is the, let's say, it's a discharge, average discharge cost, your system going up, down, or staying stable. That's not part of it. I think it really should be, especially in the hospitals in the state are almost all nonprofits. So that's food for thought. I would like to go back to the line of questioning that the Life and Health Director Lombardo mentioned. I understood from the questioning that the question was about the network composition and the reimbursement rates of, as I interpreted it, fully insured versus self-funded. And I understood from all the carriers that the same reimbursement rates that were used and the same network rates were used. If that's wrong, please correct me. I didn't have a chance to question. But it raises a couple of questions for me and a comment. And first, I'll direct this to the legislators in the room. They're all often in this building, in this very room, when we talk about state ability to influence the marketplace, we're reminded that the fully insured market is in small group is certainly the drain. It's that the state's influence is going down in a year. For testimony this morning that the reimbursement rates that the fully insured plan they are the same as the self-funded plan. So we're able to get a hold of the rates in the fully insured market. I think there's a good chance we could have bleed over into the self-funded plan where typically you don't have so much authority. But with that background, I would ask the carriers, my understanding, and correct me again if I'm wrong, but my understanding is that small businesses, small groups in the state have an opportunity to buy a level fund product even down to very small groups. They're called level fund plans, and the premiums are often less than they might be in the full insured market, which we're here talking about today. So I want to ask you, given that the reimbursement rates are the same, why, in your view, are the premiums less for a self-funded small group? And and does it have anything to do with those groups' ability to use medical underwriting?
Well, let me speak to the actual aspect of it, and then Brendan, we have some on the business side of it. Just to one of the biggest risks to operate in the small market that we have in Connecticut. It's a significant risk there. We probably saw some areas already pulling out. The reason for that is whenever you do the pricing for the small group ACA, we only have one chance to file our rates in years. And then there might be a limited kind of change in assumption for July. And that's it. Whatever the rates that we have, it's going to be remain at the same level or whatever we file and approve in state for 4 years. For all the states, they allow to change their assumption and update their rate filings and all that. So that's the to a highly risky environment that we have to operate.
Yeah, and I would just add, I mean, from a competitive position, if nothing more, we have competitors out there that are actually selling level funded products. There is a high demand for obviously the employers here in the state of Connecticut to find lower cost alternatives, and we're just simply trying to compete.
Thank you. I can start, and then Kristen, feel free to pile on after my initial comments. As part of the ACA specifically in the small group ACA market, we are very limited in the factors that we can utilize as part of our rate development on a year-over-year basis. As you called out, medical underwriting specifically is a not allowed piece of our filings. We rate on a single risk pool using the experience from 2022 to move forward that experience with potential changes for maybe 4 items specifically in the way that we actually fill into our file rate. In a level funded space, there is underwriting that is able to happen based on the broader aspects of the group that exists there. And it does allow for especially healthier groups that normally would be paying the same rate as a more or less healthy group within the fully insured space to pay a lower premium that is more specific to their specific company within the level funded space in particular. And so what we have seen over the past few years is more and more healthy groups that have left the market from a fully insured perspective to migrate to level funded group plans specifically, both within the state of Connecticut, but then more broadly across small group plans nationally. So, Kristen, anything to add beyond that?
Sorry, I'm unmuting myself here. So just a couple thoughts around level funding versus fully insured. You can tailor in the self-funded world your product design to more meet what the employer might be looking for. So definitely some flexibility in plan design. The other piece to consider too is state mandates. Self-funded plans don't have to adhere to any of the state mandates. So again, back to flexibility of plan design, et cetera. I think those two, if I think about selling a small group, a ASO or a self-funded product, those are probably the two components that most gravitate to and what we tend to have the most conversation around.
Just real quick, I have long been a proponent that these hearings should not be focused on the premium alone, because the premium from the customer experience is only one side of a two-sided coin. The other side being the deductibles and all in the cost, the out-of-pocket and access and so forth. So the customers have to pay not only the premium, they also have to pay the why aren't the rate filings, why don't the rate filings contain an analysis of your client's projected all-in cost experience for the next year as well? Would that be something that would make it a more full examination of the actual, because remember, that the commissioner here has to determine whether the rates are excessive, inadequate, or unfairly discriminatory for the insurance provider. And if we don't understand what the patient responsibility is, we don't know what the insurance being provided actually is. What are your thoughts on that?
Would you like me to start? I could take the first crack this time around. Yeah, so we actually do provide that information as part of our filing. Within the Unified Rate Review template, which is a standard CMS required document that we submit as part of each of our state small group filings. We do provide prospective information for each plan as well as in aggregate, the expected allowed versus incurred costs. So the allowed cost being the total cost, the incurred cost being what the plan or employer will actually pay as part of that plan. The difference between those two is really the member cost there. And so what the member will incur as part of being a part of that plan specifically. Beyond that, we also provide actuarial value calculations as part of our filing, which the actuarial value is really a signifier of what we expect to be the plan component that is paid during the course of the respective year versus that which is the member cost.
Okay, Connecticut, so I just heard Signa say that some of the information is already provided, but that it is useful to think about and look at all in cost. My question to you again is the same, should that be highlighted in your filings and frankly in the insurance commissioner's review?
I would highlight specific points in that actuarial value calculation as a metric for what the member and a plan split will be of actual cost. There are also guidelines around that actuarial value in each middle tier that require us to offer an actuarial value within a certain range. And so we abide by those as we're setting our rates as well.
Actuarial value is very important. You all from how much premium you collect is virtually irrelevant. It's virtually the actuarial value is virtually irrelevant to an individual patient. Let me just, and this is a real brief question, but what, if you know, and we'll start, since I'm talking to Connecticut, we'll start there. How many of your folks in the fully insured individual market do you know hit their deductible or their out-of-pocket maximum percentage?
I don't
Signa?
We rate using a single risk pool, so we don't look at plan level experience or member level experience as part of the analysis, and then prospective rate determination in the small group space.
Anything perspective from you there? My last question.
At some point in the past, we did provide information, not part of the rate filings, but at some of the events, right, we did provide that information, like how many people did the deductible and also how many people did the maximum amount.
Yeah. So I would just suggest that as part of the rate review, this should be highlighted front and center, that information is available and would be very valuable to consumers to be able to compare what their likely experience would be on an all-in basis, that premium plus patient responsibility when they're shopping for plans and when they're doing final decisions as well. Thank you so much for the time.
Thank you, Terry. If I could just take 1 more minute to go back over exactly my question. Hopefully do, and I think I heard from everyone, get everybody, all the stakeholders together in conflict. And let's, again, you see the face of the organization. We've been here, we've been doing this. What has been the results? Have there been any initiatives that we have to look at this year? Has it had any effect on the waiver plus? And if not now, when? And any order you wish to answer.
Yeah, I mean, I think some of it goes back to the original testimony that I put out in the beginning of the session today, but and I've said this a few times, I do think getting everybody together is a big component of that. A lot of the provider negotiations that we've had sparked a lot of this conversation about value-based care and drive towards value-based care. So I've said it probably too many times for you guys to count at this point today, but yeah, I do think that is going to be the significant change that we're all looking for. And having those influencers in the room, not just having the carriers speak to it, but the hospital systems, the providers, the pharmaceutical companies, the state, the legislature, I mean, everybody needs to be part of that conversation to really kind of tackle this issue.
Yeah, in the spirit of responding or how we can help or what we should focus on, I guess my answer is price transparency. I think you'll hear from us that we continue to offer pretty broad networks to small group buyers because that's what they prefer. In the past, we have tried to narrow the network and it hasn't worked out that well. So we continue to offer broad-based PPO type style because that's what the small employers buy and the employees that their companies prefer. However, that doesn't mean that they have to use everybody. We have an opportunity, both as industry as well as public policy, to help individuals who actually make the decisions where to go get care, understand where it is, are they the higher performing, lower cost providers? Right, so Cigna goes through a whole process of designating specialists, we call it Cigna Care designation, both cost and quality, and try to make it easier. Because if there is one thing that's really, really hard, it is modifying customer behavior, right, on a consistent basis. So anything that you can do leveraging the All Care clinical database, there's a lot more data available due to the Federal No Surprises Act that's out there in terms of what different hospital systems charge for the same service. Having that information provided in a trusted, consistent, reliable manner that may or may not come from their carrier might move the needle in terms of changing customer behavior to actually self-select a higher performing, lower cost provider, which we all would prefer.
I thought those are great ideas, and we agree with them, and I also think, if we could put some teeth in the benchmarks, like some of the other states have done, like they mentioned earlier. Well,
Thank you. And with that, we will now hear from the chairs and ranking members of the Insurance and Real Estate Committee, for folks here today. Thank you for giving us the space in which we meet. Let me begin with the co-chair, House co-chair of the Insurance and Real Estate Committee, Representative Larry.
Hi, thank you, Commissioner Hayes and the entire team. The Office of the Healthcare Advocate, Attorney General's Office, OHS, and all the members that are here. I look around this room and I see, I think, some of the most talented people in the state government and some of the most successful insurance carriers in the country that are here in Connecticut. And I had hoped that we would be doing a little bit better than we are now, because this is really the insurance capital, this is how, and I'm a little disappointed that we're not moving in the direction of thinking outside the box and doing things differently. We, as a legislature, recently passed to allow captives to domicile here with a tax incentive. And we looked at our Connecticut captive sector to help with any of the issues that we're dealing with in the healthcare space, because they certainly did help us when it came to crumbling foundations. I just think that we can do better with the team that we have in Connecticut. I want to focus on what we do on the Insurance Real Estate Committee, which really has been focused on creating a more vibrant industry. We want the insurers to do well. We want you to hire more people and expand and create a bigger footprint here in Connecticut. But we also want to provide the best quality care that we can at the best pricing for our customers. We pass things every year in the state of Connecticut, things like co-pay accumulator requirements. We say things like you have to freeze formularies. This year we passed the step therapy bill, which removes step therapy when allowing prescribing opioids. I would assume all these things raise costs. Would you agree? I see a lot of heads shaking. What about the benchmark? Do you pass on the staffing and time that goes into that on customers?
Which benchmark are you referring to?
The recent benchmarking that we passed, part of the executive order for requiring data for us to analyze regarding pricing.
For the customer benchmark.
Yeah.
Specifically. We look at, especially on the administrative cost side of things, as it relates to staffing, to overhead costs, to items that continue to keep our business running on a day-to-day basis. That feeds into the administrative expense that we charge as part of our premiums for 2024. Cigna has an ACA medical loss ratio of 87%, meaning that 87% of what we are charging from a premium perspective is due to claims. The remaining portion is due to administrative expense taxes, fees, and then risk and profit margin. So it does in a way get passed into the administrative expense that folks are working on it as part of our small group space.
I assume that's the answer that other first ones to clarify, but I think my point here is just to say that we're doing things every year in the legislature that's driving up costs, but we're not having that communication back and forth. I mean, we're really proud of benchmark. You know, I felt like for the first time in a long time, Connecticut could say we're collecting data, we're looking at trends, we're gonna make better decisions going forward. But if we are having customer costs go up, you know, I think that's a discussion that we probably should have on the front end. So some of the other questions that I had were things like, some other things that our committee talked about, which is, would lowering the premium tax reduce costs to customers? Yes or no? I see a lot of head shaking. Yes. Would allowing small groups to pool their risk reduce costs? Yes. Would maybe we consider that these are bills that our committee tried to get passed but did not move forward? So again, we're passing things that are causing pricing to go up. We are not passing things that would potentially save customers money. You know, I just want to throw out a statement. I mean, maybe we move these legislative mandates to, you know, if it's important to the state, we pay for them differently rather than pushing those costs on customers. You know, lastly, I just want to end that we also tried to pass a bill, it passed in the House this year, which would give the legislative process just a cost benefit analysis. And even a cost on a per member per month policies that we try to pass. Are you as insurers able to provide us that data? If I say for, you know, we have something that says you have to cover adult children to the age of 26 coverage, would you be able to give us the cost per member per month level?
So I think it depends on the act. So we might be able to on some and maybe not on others, but in general, yeah, we can provide some estimates.
I mean, because that's really great to hear, because we have been asking for this data, and I think it would give us better tools at our fingertips, working, you know, providing the best for customers. We didn't get that bill passed, but I think having more data at our fingertips would give us better tools moving forward. And, you know, I feel like we've heard this last year that we're gonna work together in a better way. We're gonna need more, you know, hopefully we are able to do that going forward, because as I said, we have some of the most talented people in the industry sitting around the table and in the state. And I know that we can do a better job.
Thank you, Representative Wood. And now we move to the other issue of the insurance and real estate committee. Senator Jorge Rivera. Senator.
Thank you, Commissioner. Thank you all for being here, and thank you, Department, for being here for your questions. Of course, to my co-chairman, colleagues, and President Floyd, Mayor Vaughn, and of course, Mr. Doolittle, for Secretary General, for being here. I like these two things. One, I like to, which I submitted for the record, Commissioner, my statement on these rate increases, and also just reflect a little on my takeaway of being here, to instructor around 9, listening to some of the questions, some of the back and forth. So I'll begin with that. On behalf of the residents of my 7th district down Prospect, I'm here to urge you, this Commissioner and departments to reject and propose insurance rate increases on individual health plans and small group plans. These proposed increases, 12.4% for individual health plans and 14.8% on small group plans, are simply unaffordable and unsustainable for those who need this coverage the most. Yeah, you know, in Connecticut, many of our middle and lower class families are already burdened with current cost of health insurance, and these increases would only exacerbate that problem. We have families who sometimes must decide between life-saving medication and putting food on the table at night. I've spoken to many of these people. While we've taken several steps over the years, as alluded, to address the rising cost of healthcare and prescription drugs, people simply cannot afford these increases like the ones we propose this year. In 2022, just a year ago, we saw proposed rate increases of 20%. At a time when that average was 10% across the nation. We're now asking residents or consumers to shoulder another request of double-digit rate increases that will undoubtedly price some out of there. It is uncomfortable to me, and I hope it is to you, to think that the residents of our state need to continue to pay excessive rate increases year after year while we see smart profits in the insurance industry. I've had the opportunity to sit here since about 9 and listen to some of the questions and some of the answers back and forth, and quite frankly, respectfully, have not heard the justification for these increases. Whether it's the incredible price variation that we saw that was eye-popping that the Office of Healthcare Strategy showed us today, the lack of providing direct information on whether mandates we pass, how that's tied to premium increases, in so many ways, so many levels. These increases are unconscionable. And I would encourage the department to reject these increases. The families of the state, the families I represent in the Senate and throughout the state deserve more transparency. They deserve more of an argument. And quite frankly, they don't feel today. I hope that I can be proven wrong. I just don't feel like you're really going to that for our residents. They're really fighting responsibility in the negotiations. Perhaps I can be proven wrong. I welcome that. I try to be a reasonable person. So, but today I would encourage that we reject these increases. Thank you, Commissioner.
Thank you, Senator Rivera. And now we turn to the ranking member from the Senate, Senator Tony Long.
Thank you, Commissioner. Good afternoon, everyone. I want to thank all the people that are present here today in the audience, and although people may be watching online as well. Now, this is an informational insurance committee review and exchange with regards to these carriers on their rate increase requests for individual small business groups. It's important to note that this sector are small businesses and individuals that, to me, are the engine of our economic sustainability as a state. We're putting an incredible burden on these entities, and it's not just this year, it's last year when we had the public hearing today in this building, but for the past decade, these rate increases are absolutely unsustainable. I mean, it's up and down Main Street, Democrat, Republican, every aspect of administration. It has been clearly defined that these rate increases are unsustainable and unaffordable, and particularly affecting a marketplace that is truly a narrow marketplace in which, and let me repeat, they are the engine of our economy. You're putting small businesses, sole proprietor entrepreneurs, and you're driving them out of the state, and you're impacting our economic vitality as a state. Let me be clear on that. So it is unaffordable, it is unsustainable, and I think my request is that we say no to these rate increases. But I want to reiterate a point that was made by the Attorney General last year, and I'll repeat again this year. I simply wish that we had more of an evidentiary exchange, more of an opportunity to delve into your business operations as a whole. When I talk to people up and down Main Street, there's tremendous irony that you are making these rate requests and you're providing tremendous actuarial and business justifications, and I respect all of that. But there's an ironic twist when you see Wall Street earnings, senior level executives compensation, that is, and that just seems to be inconsistent. So I want to echo again a request that should we have these meetings and into the future, that we have an exchange of an evidentiary exchange that was offered by the Attorney General to delve into your complete business practices and how your dollars and cents and your P&L mesh in with the rate and cost of healthcare management. And I know it's a tall ask, but nevertheless, I think it's important to note that. And I actually do have specific questions, so I'll get right to the question because of limited time. But before I begin, I want to take an extra second to acknowledge the leadership of Commissioner Mays. We're here in the LOB, not at the insurance department office. We are live on Zoom or online on CTN.
because we have made the request of the legislative committee leadership to have this where people can hear the exchange. It's not a happening that occurs almost like an annual rites of passage in the middle of summer in a building that nobody knows about. This is in the people's building. I think it's a move forward. So I want to thank the commissioner for his consideration of our request. So I have a couple of real quick questions, and it may not have all the answers today, but let me begin by simply asking. The first question is vertical integration and health consolidations. Anthem, you now have just started a new in-house PBM, and you created a twist in California where you're saying we're not going to go with Caremark because you're creating your own PBM, and you've got Cigna, you own Express Script, and you know, Aetna, who's not present in requesting this marketplace, as obviously Caremark. The vertical integration and one of the biggest factors of our cost increases, prescription drugs. But this kind of vertical integration that you as companies control, ConnectCare, I think you're excluded from that integration. And I think you mentioned earlier that you're at a distinct disadvantage because you don't have that economy of scale that you're offering. Is your cost and rate increase consideration tied into your business operations with your PPMs? That's my first question for you, Commissioner.
Any particular member, or would you like? Would you like?
I think it would be applicable to Anthem with their PBR, except PB, whatever the company name, trying to get used to it. Carolina, and obviously Cigna with the Express Script.
Yeah, I mean, from my perspective, you know, we've had difficulty in years past when we didn't have an integrated PBM to manage costs. I think by bringing that in-house, it allows us the opportunity to really take a look at pharmacy spend and create different and unique programs that will help us manage that. And I mentioned California. I would say California and Connecticut are separate entities, so while it's all under the Elevance umbrella, and Connecticut does operate separately. But we do Carolina RX, this new in-house company, so to speak, to provide us additional opportunities that help better manage costs and drive down the cost of healthcare.
Yeah, so
I can jump in here. Jeff, are you going?
Yeah, we got it. You can jump in. So to your initial question, the Signal plus Oscar financial statement is completely separate from the PPM statement. We are very much using them as a service. I'll echo, because we're under the same umbrella, we do have operational efficiencies, administrative efficiencies, basically some personal efficiencies. I can get on the phone and call people over there and vice versa, that we can actually integrate both the pharmacy and the medical and the people together to actually try to lower costs and lower administrative costs overall, but we wouldn't necessarily have, we weren't under the same umbrella.
If I may, Commissioner, just to follow up on that question, I think, again, that what I'm hearing is the fact that your rate request and your actuarial presentation and your justification for this increase does not tie into your other business operations, such as your PBM internal or any other business. Although it's kind of interesting to me, one of the shot across the bow, even after the rate request, was a memo that I read that the rate might increase based upon legislative changes. So you're considering all the various factors that affect your business, but we don't get a complete picture of how you operate as a business. It's almost very similar to our electric utilities. You have different buckets and the consumer pays for what you base on your cost. Whereas other aspects of your business, because of vertical integration, is not being counted. So again, let me echo what has been said before, and I will repeat again, I would encourage that when we look at rate increases, we look at it from an evidentiary and a robust look at how you operate as a business. But I recognize the time constraints. I'll go to my second question. Artificial marketplace of Medicare and Medicaid. You know, it's evident by the recent benchmarking, which I greatly applaud Commissioner Gifford and the governor's office, as well as the legislative body, and pushing for benchmarking that began as an executive order that was reaffirmed legislatively and produced the first round of benchmarking report. what was shocking to me was the fact that the benchmarking report, I don't have the exact percentages, but the self-insured marketplace and the fully insured marketplace saw increases over double digits in regards to healthcare costs. But at the same time, what's starting to me was Medicare, Medicaid, government managed was artificially low. I think it was less than 5%. So knowing what we've done in the insurance committee with our innumerable meetings, listening to the experts, understanding the escalating cost of healthcare in the entire ecosystem, how do you quantify the fact that this is an uneven number? How is it that you know, is healthcare insurance costs treated differently between the paying private market of the fully insured and the self-insured versus Medicaid, Medicare? Or is it the private payer marketplace subsidizing an unrealistic healthcare cost system of this entire ecosystem health cost that we've heard repeatedly in your presentation? I'd like to get your surmise why the discrepancy differences. And you're looking at insurance rate increase at artificially constrained low cost of how you guys ask for reimbursement in that marketplace. I'd like to get some clarification from all of you. Is it artificial? Is it unsustainable? Or are private payers subsidizing the Medicaid, Medicare marketplace? Through you, Commissioner.
Thank you, Senator. Let's begin with Medicare.
So, you know, I know there's a study out there that says that does not happen if it's not cross-subsidization, but I don't believe that study at all. You know, I don't have numbers to give to you that said that, but I've been across the negotiating table many times, 30 years, doing this for a long time. And you know, the hospital systems and other providers, they can't get more money out of the government, they're going to try and go after the commercial market. And you know, they're building, they're growing, and they need financing for that. So at the end of the day, you know, we do believe that on one side, government kind of keep the prices for Medicare and Medicaid down, but on the commercial side, it creates a balloon effect.
Thank you for the question. I would agree with Medicare specifically on some of the items that they have called out. Well, it is, you know, my own personal opinion, you know, in terms of how we think about the commercial market and subsidization of the government market. I believe Executive Director Giffords had presented information on some of the percent of Medicare items today, the lowest of which was 160 or 170% in Connecticut. Up to a range of over 300% versus what is paid on Medicare specifically. So it looks at as specific elements that we tend to pay a much higher cost than what is paid in Medicare or Medicaid space.
Yeah, and I would simply just echo the comments made by Connecticut and Signal plus Oscar here. You know, Medicare is 80% of the healthcare dollar, Medicaid is about 50% of the healthcare spend. Providers need to make up the delta, and private carriers are the ones that are paying for it.
Thank you. I respect the time and obviously I have many questions because of the good work that we've done on the insurance committee. I want to commend the leadership of our two chairs here. I'm appreciative of being able to work with such good talented people. And thank you again, Commissioner. I wish I had more time and more opportunity to kind of delve into the marketplace that we've been afforded in the insurance committee. And my hope is with the chair's potential approval that we would welcome you back in an insurance and real estate committee informational hearing that we can indeed delve into more of the concerns and healthcare costs and the integration costs that's happening in the marketplace. So out of respect for other people's allocated time, I want to thank the commissioner again and the various members here for your hard work. So there's a lot of work ahead and it's like deja vu all over again. So thank you, man. Thank you, sir.
Much appreciated. Thank you, Senator, and thank you to all the members of the insurance and real estate committee for leadership today. We will now take a short break. It's about time for a very quick lunch. So we will pause for 30 minutes and we start at 1:10.
Oh, yeah. Good weekend. It's short, right?
What have I not?
Yeah.
There's a lot of people having to come back. Yeah. Yeah.
Well, we're gonna bring you something. And then we're all gonna hit it.
I mean, there may be.
I think.
Why don't you call me?
You guys are skinny and all that, not hard, you love. Where in the shows? You had a question that they're on, I feel like. How are you? Summer. All right, I'm heading out. Bye. I was like, yeah.
I get extra.
I know. Listen.
That's like,
Meanwhile, he's going. It's away from our house. He's like, lady, the everyone. You're going. That's very cool. I'm hot. Put your ear. Huh? Let's go back with the bar. Never mind.
So one ten?
Yeah.
But they sent it.
Oh, yeah. That's all I did. I'm all. Well, they say you want the air? Yeah. This is perfect.
So that's a good thing. Right. I don't know where.
had seen sure which documentation is further.
What kind of things are popular? Oh, yeah, the other one was better.
To get my daughter one, some kind of thing.
Oh, yeah, this is not actually a World Cup.
Oh, it looks like
So,
it's a pot.
I even put in the computer here.
That's what I was thinking it was.
Perfect.
And putting together one, yeah.
Yeah, that's good. So there's always, and then she likes to share that, how I go, like I.
Well, that's right. I think you want something like that for the professional meetings, yeah.
She was probably like something more like this, but kind of natural, like.
Yeah. Like I have some of the
Yeah.
briefcases, but now I use the backpack.
Yeah.
I had this.
That's what. I thought, yeah. Very.
It's kind of cute. I had to pull that one more.
Yeah, like I said. Oh, really? Yeah.
There's a which one? Oh, there's one, the first one I went.
Oh.
That was the one.
Yeah.
I just pulled up.
Thank you, Steve, and we're about to begin. Please, thank you, Steve. Thank you all, welcome back. I hope you had a quick but early lunch. Now we will begin the public comment portion of the meeting, and we are going to begin with our elected officials. Each elected official testimony will be up to 5 minutes each. After that, we will invite members of the public to speak, and members of the public will each have up to 3 minutes to make their comments. Mary Quinn on my left will be our timekeeper. Mary will be ensuring the proceedings adhere to the allotted time. When time is up, as a courtesy to everybody else, please be prepared to conclude your remarks. Justin Kaiser, who's also at the desk, will be calling the elected officials who are signed up to speak. And now let me turn it over to Justin. Justin?
State Representative Holly Cheeseman.
And Representative Cheeseman, just for anybody else who's just coming in, these are the representatives. Feel free to direct questions.
All right, thank you. Well, having heard some of the hearing before, I think the questions have been pretty comprehensive. And I believe the Attorney General referenced Groundhog Day in his press conference, and to a certain extent, it feels that way. But as I sit here today and we listen to these requests for rate increases, I too bemoan the fact that we don't have other players here to address this. The healthcare advocate, Ted Doolittle, address the need to have the hospitals in the room. We are looking at a medical system dominated by two networks. A duopoly. We are looking at, in effect, at only two games in town. And as these gentlemen whom you questioned before and lady sit here, what ability do they really have to drive those rates? Anyone who's received an explanation of benefits looks at, if you have insurance, this is what the provider billed, this is what they accepted in payment. Yet if you have no health insurance, that same provider will dun you for that full rate. How does that make any sense? We've heard about the private rates underpinning the rates that are paid for Medicare and Medicaid. We will not have a solution until we have all the parties in the room. Because you can't address the rates that are being passed down without addressing the rates the providers are demanding as they are the only games in town, have increasing weight to dictate how much everyone is going to pay. As someone who just a few years ago was buying health insurance on the individual market, I am only too aware of the horror you get when you get that bill before you've reached your deductible. How can you justify $50 for one shot of neosynephrine up a 2-year-old's nose? And I recall that because when my young son's stuffy beat up his nose many years ago, that was the rate we were charged. I could have started at CVS and picked it up for 99 cents. So again, I think for any kind of solution to this, we need to address not only the rates being asked for by the insurers, but the providers to look at that duopoly system. In my part of the state that used to be dominated by Yale and Haven Health, Hartford Healthcare is opening facilities, Bond have doctors' offices. How can you ever negotiate when you have so little leverage, because these are the only games in town? And let's not get started on the circular firing squad that is the pharmaceutical companies and the health insurers and the hospitals and the PBM managers. We look at performance-based rate making and now in the energy industry. Well, why not look at performance-based rate making the way Medicare does with these insurers? There's one hospital group in the state that participates in Leapfrog that actually has their hospitals and services rated. There's another that doesn't. If I'm looking for good medical care, I'm looking for a hospital group that puts customers first, really enables their staff to do the best job, and sends me home healthy. We have 400,000 people a year who die of unforced medical errors. Why aren't we addressing that? So this is a wide-ranging conversation. I am so happy that we've had this hearing again this year, but I think Connecticut and its residents deserve everyone to be at the table. And this conversation, not just to include insurance companies, but to include the providers, to include the pharmaceutical companies and the PBM managers, because only at looking at all the root causes are we ever going to find the kind of relief our residents need and deserve. And with that, I will conclude my comments.
Thank you, Rosalynn. Are there any questions that you want to add?
No, I listened to the hearing before. I think I heard some very interesting answers. I know you're going to look carefully at this, but I think we need a much more holistic approach if we're going to find a solution to this problem.
Thank you.
Thank you very much for your time.
Representative Tom Delnicky.
Good afternoon, Commissioner. I've been attending these hearings since 2017. And I can recall the first hearing I attended. I think I was the only legislator there, and it was your predecessor, Commissioner Wade, I think. And the more things change, the more they seem to stay the same. I've heard basically the same arguments for maintaining the rates, that we need the rates, et cetera. And Commissioner, I want to applaud you because I took a look at your website and I want to read something that I found on your website. We've got your back. The insurance department is committed to consumer protection. To accomplish this, we make sure that the insurance companies follow state laws and treat you fairly. We offer guidance, support, and education and regulate the industry in a way that promotes fair competition and make sure insurance is available for everyone. And I would ask that on that statement, because I love that statement, that it's available to everyone at an affordable price. Because if you can't afford it, it does you no good. You know, no one has talked about the back end, the elephant in the room. No one has talked about just what these companies have in the way of a gross profit. Because the bottom line, it drives everything, really, when you think about it. Because they're in business to make money. And I went online, I took a little bit of doing, and I found some information. Elements, $27 billion with a B. Cigna, $148 billion. CVS Health, $125 billion. United Health, $79 billion. I looked at those numbers and I couldn't believe it. That the profits are that high, gross profits. And I will concede that I'm sure the actual profits are less, but the point being, those numbers are astronomical. And of course, CEO compensation is another issue that I've heard from my constituents. What are the CEOs making? And they range everywhere from 37 million down to 23 million for those companies. And if you think about what a family is doing right now to make ends meet, and you think about the gross profits, part of this discussion should be gross and net profit, because that drives everything when you think about it. Because you've got stockholders, you've got shareholders, but you also are delivering a product that is above and beyond the pale. And when I say that, everyone needs some form of health insurance for the safety of them and their family so that they can have some peace of mind. And if it's a high deductible plan, I don't know how somebody can actually benefit from it. And when I look at the various increases that have been proposed, Connecticut, an average request of 15%, Aetna, an average request of 10.9, Cigna, an average request of 23%, Oxford 7.5, Oxford Health Insurance 8.5, United 8.2, and on and on and on. The Attorney General spoke about the actuaries and benchmarking. And recently I had the privilege of attending an Office of Health Strategy meeting where they talked about benchmarking, they talked about all of that. And it's interesting to note the benchmark for 2024 is 2.9%. Is that any information I'm not running out of time? No, okay. Heard that. And the state employee health plan to this point is at 3.7%. Far below what the asks are. And is it, you know, the old deal about you go in to buy a car and the asking price is here, the buying price is there, and somewhere in between, you reach a happy medium. Well, that's not the way this should be. Yes, the insurance companies deserve to make some kind of profit. And no, it shouldn't be what they're making now. And Commissioner, you have a tough job here. Because we're looking at what's going on here. And quite frankly, at some point, the legislature might have to step in and give you some help. Because this can't keep going on. We can't keep seeing these sky-high increases being proposed and then something less than that being accepted. There's a point at which you reach a tipping point. And we are coming up to that point. And I've got to tell you, all eyes are watching what's going to come from the insurance commissioner's office on these rates. Because this is an unsustainable situation we've got here. Of these increases exponentially, the gross profits in billions of dollars, the compensation to CEOs in 20, 30 millions of dollars. And Mr. and Mrs. Connecticut, the folks that are just trying to make ends meet. They've been hit with 12% inflation. They're in a situation where they're not getting a raise like that. And they're having to scrimp. And now they're worried not only about health insurance, and I feel like I'm jumping ahead, but they're also worried about what the home heating season is going to bring. We're squeezing the middle class, and that's just plain not acceptable. So I thank you for the opportunity, and Commissioner, please have the people's back like your website says, because that says a lot what you have in that statement.
Thank you, Representative. Good to see you again. And go ahead.
Next is Senator Kevin Kelly.
Good afternoon, Commissioner, and all esteemed members of the dais this afternoon. Thank you for the opportunity to be here and to voice our perspective. 10 years, it's been 10 years since passing the Affordable Care Act, and healthcare in Connecticut remains unaffordable. After a decade of Democrat control, wherein they held every lever of Connecticut's political power, both here in Hartford and Washington, they are failing to deliver on their promise of affordable health care, improved quality, and greater access to medical care. Healthcare deserts and healthcare insurance premiums, the size of mortgage payments, rule the day, making it more difficult for working and middle-class families to find, get, and pay for the quality care that they were promised. This is a right they deserve, but yet it seems elusive. Instead, the majority stands in the way of delivering on their promise. The most recent example of this is the failure to pass legislation more commonly known as association health plans, which would lower premiums for small employers who are the backbone of Connecticut's economy, hurting both healthcare and jobs for the people that live in our state. This year, across the country, we're seeing the median income in health premiums at 6%. But here in our state, Connecticut, it's twice that. It's 12%. We've become an outlier. And it's yet another reason why Connecticut is so expensive. My message is simple. Connecticut Democrats promised affordable health care and are failing to deliver. They are long on promises and short on delivery. Our working and middle-class families deserve better. And Senate Republicans proposed a better way to lower health care costs, which included Much talked about today, Massachusetts Republican Governor Charlie Baker's benchmarking plan. Also, we proposed initiatives to control drug increases. And also our proposal with regards to reinsurance that lowers premiums by 30%, which would save the average family of four up to about $7,500 a year. If only there were more Republicans in the legislature, then our working and middle class families would get the relief that was promised and the relief that they deserve. Until that happens, I urge all of you to bring the affordability that the majority fails to deliver. Thank you.
Thank you, Senator Kelly. Justin?
Next up is Senator Martha Marks. I don't see Senator Marks on the Zoom or in the room. So the next person is in the members of the public.
Thank you, Justin. Thank you to our elected and appointed officials who have testified here today. I do believe, as Justin said, that brings us to the end of all this. The appointed and elected officials, we will now open it up to the members of the public who signed up to testify.
Sir?
Justin.
Before you do, I was wondering if I could speak. I have my hand raised, but I don't know if you guys can see that on Zoom.
Justin?
It's not on the list, but I don't think so.
Please. Do we? Not sure what happened here.
Oh, yeah, Representative Nuccio, go right ahead.
Okay, thank you very much. Listening to today's meeting has been a little enlightening and a little bit of the same for me. So from the enlightening perspective, I first want to compliment you, Commissioner, on bringing in Dr. Gifford. Working with OHS, since I've been in the legislature for the last 3 years, I have very consistently had the same message that we need to look at the underlying cost of healthcare when we are considering these rate increases. And her presentation on the benchmark, I thought was very enlightening. And I'm a little shocked because the Attorney General's comments didn't even reflect what we had seen there. And some of the other people who have spoken so far, their comments don't reflect what she is very clearly saying from these benchmark numbers, which is the majority of this increase is because of the increased cost of care. And looking at the cost of care in the state of Connecticut in comparison to the states around us, so close as Massachusetts and Rhode Island, and at a national level, Connecticut is some of the highest healthcare costs in the country. As the good Representative Cheeseman mentioned, we have seen a massive consolidation of hospitals. We've seen Hartford Healthcare and Yale and Trinity, which is a smaller player in it, but still one of the larger networks, buying up all of these small hospitals throughout the state, and then closing down key services and driving them toward their metropolitan offices, which to me just shows a pattern of abuse that we need to really address. When you're closing down maternity in every small hospital in the state and saying you have to go to Hartford or Bridgeport or New Haven to give birth, and we see those numbers that Dr. Gifford is putting up showing that Hartford, Bridgeport, and New Haven are 20 to 30+% higher than the national average for cost of care, or higher than the states around us. That is alarming. It is alarming. And I know that's not something that falls underneath your jurisdiction, but I felt it necessary to talk about that for a couple of minutes. When you look at the product that you are regulating here, it is the fully insured product. It is a very small portion of any of these insurance companies that came forward today. It's a very small portion of their business. And it's the most regulated piece with the mandate of the 85-15 split from a federal level for the MLR. I do think some of these, actually all of these rate increases are extremely high and should be pushed back on. And in the last rate review that we had, I mentioned I would love to see, we talked about medical trend and claim cost and the MLR that these companies have. I would like to see a more granular breakdown between the MLR, between administration and profit. And then consider which portion of the business is this fully insured business for those companies. And maybe we say, no, we're not going to allow a 2 to 3% profit for this. We're going to cut back. You have to show the difference between the administration and the profit in the actual claim cost, but it's minimal. When you look at that number, 2 to 3% profit, you want to bring down the profits of the company. You need to bring down the cost of the care, because it's literally how it's established and set up. So having Dr. Gifford here, I thought was very key, because she is starting to bring light to the fact that as Attorney General Tong said, 5% across the country for claim experience. Clearly, he wasn't looking at what Deirdre was showing, which was 18 plus, almost 19% medical claim cost in the state of Connecticut, one of the highest cost areas in the country, right? So we need to determine, why is Connecticut one of the highest cost medical providers in the country? What is driving that? We had several of these insurance companies talking about the mandates, and I find it a little disheartening that they can't really sit down and say, this is how much the mandates are driving, right? We should be able to, from a claims perspective, it's CPT codes, it's diagnoses, it's procedures. You should be able to identify what the claim volume is that is being driven by mandates. And I'd like to see that broken out, because I think that's beneficial for the legislators. My question and my impetus for wanting to speak here, sir, is I know it's not within your purview to really consider the benchmarking. And I know currently the way that it's written, it's not within the Attorney General's purview to look at the certificate of need and doing what Rhode Island's Attorney General did, which I think is beyond admirable, and it's actually going after the hospitals and such, or the companies that are higher than the cost benchmark, and putting some teeth behind it. Massachusetts has started looking at putting teeth behind, if you exceed the cost benchmark, you're going to be penalized. And I think that's going to be the only way we can try to keep these hospitals' costs in check. Being in the industry, I understand how negotiation works, and insurance companies don't really have a lot of power with negotiation, which it always flabbergasts me when people say that they do, because we have a network. I've seen hospital networks hold insurance companies and multiple insurance companies hostage to say, you will give me a 20% increase, or we're going to not allow you to have any of your clients come here. We need to level the scales on the power to negotiate for insurance companies. And more importantly, we need to really work on the crossover between you and OHS and the legislature to look at, you ultimately approve or deny the rates increase. The rate increase is, in a perfect world, based off of claims experience and medical trend. And as those go up, the cost of insurance goes up. Yes.
Please summarize.
Okay, thank you. What I would like to really see is a mix, more working together between the Department of Insurance, OHS, and the legislature to truly find a way to bring down the cost of healthcare. That's what's driving these increases. And I ask that we look at that and really scrutinize what the insurance companies are putting forward from a claim experience and compare that to the benchmark information, and try to find a way to truly make a change for the people of Connecticut, and that is to bring down the exorbitant cost of healthcare in the state of Connecticut.
Thank you, Representative. And John, allow me to apologize. We did not realize you were seeking to speak. And are there any other elected officials who are online, elected or appointed officials, who would like to speak? Hearing none, we will now turn to the members of the public who have signed up to speak. I do ask that you limit your testimony to 3 minutes and state your name at the beginning of your comments. Justin will call each speaker at the beginning of the session. Justin.
First up is James Sterling.
Good afternoon, Commissioner Moss and members here today. I'm I heard with great interest the presentations by the insurance companies today. My remarks have changed, having been here since 9 o'clock. I generally agree with the insurance company's position about why their costs go up. I should say that I've been a licensed insurance agent in the state for 37 years. My family's business was a third-party administrator. We designed and administered self-funded health plans for Connecticut employers. So I've seen this industry from the inside. I want to make sure that we know that a lot of people have talked about the stakeholders need to be broadened in these hearings. And we're talking about carriers, and now we need to talk to the providers about how to bring those costs down. There's a couple of other stakeholders that are not represented here. That's the employers who pay the premium and the employees and their families who bear the brunt of those costs. They need to be included. And I also want to point out that the carriers, the providers, and the consultants all benefit from increasing costs. There's no increasing profit if we hold down costs. The Affordable Care Act changed the dynamic in the state because under the ACA, the medical loss ratio limits how much carriers can make in profit based on their premiums and the cost of claims. So the only way to increase profits year on year is to increase premiums. The brokers who I worked with for 30 years, if they receive a 4% commission and the best they can do for the employer is say, it's too bad, but the best deal now is a 15% increase. If they're getting 4% of that, they just got a 15% increase in rates. So all of the major stakeholders have an incentive to raise costs, except for the employers and the consumers. So to get to them, we need to address the broken system, which is within the Department of Insurance authority. One of the things that Massachusetts has done is they have the same rates for small group products and individual products. Now, I heard Paul, you asked, is it the same plan and the same network for large group, ERISA, and small group? But that question did not extend to the individual market. There's a new product that allows the employer to stop choosing healthcare for their employees. It's an individual HRA, individual ICHRA. So an employer could say, every employee who's 21 years old, you have $650, go buy an individual product and scale that times 3 to the 64-year-old so that they can go buy their own product. That would change the market entirely. And I would suggest that that would require some consideration into the future. Thank you.
Thank you.
Next is TJ Clark, who I believe is on Zoom. TJ?
Good afternoon. Can you hear me?
Yes.
My name is TJ Clark, and good afternoon, Insurance Commissioner Mayes and the Connecticut Department of Insurance. Thank you for allowing me to speak about the proposed 2024 health insurance rate increases. I'm the Executive Director of the Connecticut Oral Health Initiative. Our mission is to strengthen and safeguard access to quality, affordable health services for all Connecticut residents. We desire that all Connecticut residents will have equal opportunity to obtain the services needed to maintain good oral health. COHI is the only statewide organization that solely advocates for equitable oral health policies. I'm writing to express my deep concern regarding the potential increase in health insurance premiums by insurance companies in the state of Connecticut. I strongly urge you to consider the financial hardships that such increases would impose on small businesses and individuals in our state, and to take proactive measures to reject any premium hikes proposed for 2024. In order to achieve this, it is imperative that insurance companies engage in meaningful negotiations with healthcare providers to establish lower rates. This collaborative approach will help alleviate the financial burden on both the insured and the providers, ensuring that the essential healthcare remains accessible and affordable for all. I would also like to draw your attention to the value-based care model, which presents a promising avenue to drive down healthcare costs while maintaining quality care. This model focuses on improving patient outcomes and promoting preventative care, thereby reducing the need for expensive treatments and hospitalizations. By embracing a value-based care approach, insurance companies can contribute significantly to lowering the overall cost of healthcare and enhancing the well-being of their policyholders. Furthermore, I would like to implore the Connecticut General Assembly to introduce a bill similar to HB 5813 that was proposed during the 2023 legislative session and unfortunately did not receive a public hearing. The General Assembly must create legislation similar to HB 5813, which aims to standardize the allocation of dental insurance premiums towards actual dental care rather than insurance company overhead. This legislation is a crucial step towards ensuring that individuals receive the dental care they require without excessive administrative costs. Statistical evidence reveals that residents.
Could you restrict your remarks to the items being discussed at this hearing? That is not a part of the hearing, it's not subject to the discussion today.
I'm sorry, I didn't hear you.
That particular proposal is not a part of this hearing and is not subject to this discussion today. So in the interest of making sure everybody has a chance to speak, could you restrict your remarks to the item, to the rate increase request we're currently discussing?
Yes, sir. That was the only comment for that bill. I will end by saying this. In conclusion, I implore you to prioritize the well-being of Connecticut's residents by taking measures to limit health insurance premium increases and adopting a value-based care model. Embracing these changes will not only ensure affordable health care for all, but also contribute to the overall health and prosperity of our state. Thank you for your attention to this pressing matter, and I'm confident that you will make the right choice on behalf of the people of Connecticut to ensure a more equitable and affordable healthcare system for all. Thank you.
Thank you. Justin?
Next on the list is David Freed, who I believe is the person. Good afternoon, Commissioner Mayes and members of the Department of Insurance. My name is Dr. David Freed. I'm here representing the Connecticut State Dental Association and its 1,400 members. Thank you for having this hearing. In the dental, the fact that we're here discussing increasing rates and transparency is admirable. But in the dental world, it doesn't exist. In the dental insurance world, there is no such thing as MLR and transparency. The medical loss ratio under the Affordable Care Act, as we've heard from many people today, is about 80%. In the dental world, it's 40 to 60%.
Dr. Freed, once again, I must ask that you restrict your comments to the rate hearing increase before us today, which was not published on that channel.
I do believe, though, that these increases that we're looking at today will be global and will affect all insurances. We've been trying to have a public hearing. We have not been heard, and the public hasn't been heard.
Doctor, the product you're talking about is a standalone dental product. The products we're talking about today are full medical that have dental and vision benefits, some of them within their medical that are part of the 80%, excuse me, medical loss ratio in the ACA. What you're discussing is dental, standalone dental that is not part of the rate filings submitted and is not part of the ACA filings that we're discussing today. So that's the difference.
Well, we would appreciate that we could have a hearing on these issues at some point, and because this issue is very important to members of the public who are paying for insurances that are way out of cost basis.
Thank you, Doctor.
Thank you.
Next on the list is Maya Taylor, who I believe is on Zoom, but I don't see her. Is she in the room?
All right, then next on the list is Marcella Oliphant.
Musical chairs. Good afternoon, Commissioner, and everyone in the respective places. I would ask that you reject the rate increase. As you know, my name is Marcella Oliphant. The reason I'm asking is because I'd like to put a face to what this discussion is about today, without being too personal. So my mother is over 80 years old. And I am an ex-employee of the state of Connecticut. And I pay both for my mother's insurance and my insurance out of pocket. So my mother is on one of the Medigap plans. She's not on the Advantage plan. And the reason I mention that is because the Medigap plan, it costs. And it's not cheap. And most people, when their parents at a certain age, they put them on Title 19. But to ensure that my mother gets excellent care, that we have more control of her care, that we have freedom to go where we want, and not have to have a gatekeeper, referral, we opt for the Medigap plan. And that plan costs about close to $4,000 a year. If this increase were to happen, you can see cost of living, COLA hasn't increased. Matter of fact, I believe in 2023, COLA increased 8.7%. In 2024, it's going to be 3%. I'd like to take this a step further in that when I add my insurance cost on top of it, like I said, I no longer work for the state. My husband worked for the state, he's retired, I was on his insurance. Money would come out of my benefits directly from this and then somehow the controller's office was to reimburse me. But somehow, I don't know what happened to the money, my husband gets reimbursed, I don't see the money. My point is, these are out-of-pocket costs that an Advantage plan is not an option. It only goes without saying that the older you get, the more care you're going to need. The Advantage plan limits if there is a limiting in that care, mainly for healthy people. Whereas the Medigap plan, and I don't want to go back and forth with this comparison, whereas the Medigap plan, you have a greater degree of care that you receive. The downside is like a two-edged sword. So in 2019, my mother had a catastrophic illness, so to speak. She was in the hospital. I'm going to show you the downside. She was in the hospital, and the hospital bill anything under the sun. Whatever they could find was equivalent. Is that makes sense? Okay. The issue with that is it's a two-edged sword when you have good insurance. The last thing I'd like to say is moving forward. On just that, on average, I don't know if it's because she's over 80, but she doesn't get the care treatment. You can see doctors who can go anywhere, the treatment that is there. My whole point in saying all this is to say, please don't do a rate increase. A rate increase would probably be another $1,000 a year. Should I get another $1,000 a year from the Medigap plan? And that we have, and it's almost unaffordable, and it would be a matter of having better care. Thank you for that.
I saw that Tanea Taylor logged onto the Zoom. Tanea, are you there?
Hi, yes. Okay, hi. My name is Tanea Taylor. I'm from Hartford, Connecticut. I am calling in today to testify against proposed rate hikes. I'm not sure if my language is correct here, but I know that just coming from a person who, struggles with multiple conditions that aren't covered under state insured care. I have a lot of out-of-pocket expenses with endometriosis, dental health care. And, for rates to go up is pretty unaffordable to me, along with rising rent costs and the cost of living. I have loved ones who are, barely covered by insurance, who are living paycheck to paycheck, taking care of children, transportation, and family. And added costs and additional hikes just would not be sustainable for their overall health. Economic health and financial well-being is a part of our physical health, because stress is a major, detriment to our bodies and our hearts and our brains and our mental health. So I just want to make sure we just have some equitable rates and that coverage for all and healthcare for all is continued to happen. Thank you so much.
Thank you.
Next is Kathleen Garrity, who I believe is on Zoom.
I am, thank you. Commissioner Mays, members of your staff, officials from the Attorney General's office, the Health Advocate's office, and the Office of Health Strategy, and elected officials, thank you very much for having this hearing today. I did hear the commissioner's remarks earlier this morning, and again, when my colleagues started speaking about certain dental insurance issues, that this is not the forum for it, and I appreciate those comments. I will try to stay on point, but please hear us that that continuing issue is something that is paramount, not just for us, but for the citizens in Connecticut. My name is Kathleen Garrity. I'm the Executive Director of the Connecticut State Dental Association, and we represent the oral healthcare professionals in Connecticut. I'm here today to express our complete dismay at the request for another round of double-digit rate hikes by insurance companies. I'm here to represent providers of healthcare in Connecticut, our patients. I'm also here as a small business owner because I run the association, which is a small business, as well as a mother who has young adult children who are trying very hard to make ends meet in this state. I hope my perspective will add to this commentary today because it's long overdue. I realize that today we're not here to talk about state-based plans, nor ERISAs, nor standalone dental plans. However, there's a lot of overlap in what I do every day and what you're hearing about today. And again, it is like Groundhog Day because we talk about this so much, and yet the frustrations of the consumers and the providers continue. Healthcare is not a luxury. Oral healthcare is not a luxury. And such, we have to work together. And I hope we will all get in a room and have a constructive blueprint that will help the citizens of Connecticut. Because very often we sit in these rooms, we hear the justification for this, the rate hikes, and we don't talk about the other factors, which are things like dental insurance programs that they do not have the same level of oversight at this point in time. As we look at these rate hikes, we have to look at how the premiums are being used for actual care. And while the medical MLRs are impressive, the reality is, where is the rest of the funding going? And unfortunately, until we have a full landscape, it's going to be very difficult for the commissioner and his staff to do their job and to do what's best for our citizens. The reality is that as we look at where we can have the overlap between the executive branch and the legislative branch, and I'm thrilled that we are actually having a lot of people that are the important faces on this policy in the room today. There's so much more that we need to do. I also wanted to point out that I was listening very intently when the insurance companies were talking about their frustration in contract negotiations with the larger hospital networks. It's indeed exactly the face of the small businesses, small business providers of healthcare when we try to negotiate our contracts with insurance companies. We are in parallel universes here. Increasingly, the trend is not to engage with small businesses, it's to deny our entry into the marketplace by making it a disadvantage to stay in the network. This is something that I hope the commissioner will look at as well. Our small businesses around the state are being crushed, not just by increased premiums to provide health insurance for our employees, but also in the decreasing reimbursements that continue to hit healthcare providers throughout the state. So as the premiums are going up, the reimbursements are going down. What doesn't go down is the compensation of the C-suites of these companies. The average citizen in Connecticut makes about $34,000.
I'm sorry to interrupt, but your time has expired. Please summarize.
I will, thank you very much. I would just point out that the average citizen in Connecticut makes $34,000 a year. The average CEO of these companies makes that in 2 hours. We need to level the playing field and do better for our patients. Thank you.
Here.
Next up is Jen Kritzman.
Good afternoon. My name is Jan Kritzman. I'm a 10-year breast cancer survivor. I live in Newington, Connecticut, 46 years. I'm the patient advocate who championed Connecticut Public Act 22-90, which is now the gold standard in the nation to mandate health insurance coverage for the earliest possible early detection of both breast and ovarian cancer with no financial barriers. No out-of-pocket costs, no copay, no co-insurance, no cost sharing for both the screening and the diagnostic essential testing for anyone with breasts and or ovaries. And for those with state-regulated individuals or small group policies, you know, the expensive plans with the killer high deductibles. Do you know why I'm here? Because I don't. You insurance experts have heard from me for 3 years now, explaining how the earliest possible early detection of both these dreaded diseases saves your companies millions and millions of dollars. It is Groundhog Day, as somebody else just said. Newsflash, the cost difference for treatment between the earliest stages of these diseases and the late stages of these diseases is enormous. And so is the prognosis. And yet, some of your companies may, I've heard, plan to highlight Public Act 22-90 as one of the legislative reasons for an impossibly burdensome rate increase request in the future. This would be crazy town, seeing that the cost to your companies for the breast and ovarian cancer mandate is a measly 0.2%. Huh? You're spending 0.2% to save for yourselves millions of dollars in late-stage breast and ovarian cancer treatments. What courses in statistics and economics did you actuaries fail to take? You should thank me and the wisdom of the Connecticut legislature and Governor Lamont for passing Public Act 22-90 last year, which is not only life-saving, but also cost-saving. And isn't that why you are here? You're welcome. For your information, there are now approximately 18 other states that are following Connecticut's lead with similar proposed breast cancer legislation, 18 states. More for your information, New Haven Congresswoman Rosa DeLauro, right here in New Haven, has proposed federal breast cancer legislation entitled the Find It Early Act. This is HR 3086 in Congress, which would mandate health insurance coverage, both private and government, with no cost sharing for both screening and diagnostic essential testing for breast cancer. If any of you have a loved one or a friend who has breasts, you really should tell them to contact their congressperson, and you should also, and tell them to co-sponsor her bill. Thank you.
Next on the list is Isabel Barber.
I wear this because I can't afford to get sick. Good afternoon. I'm here with a mother hat on and a public health professional hat on. I've been here since 8:02 this morning, expecting that I'd be able to speak around 9 or 9:30. So it takes a lot to stay here, and I have a lot. I received a bill of over $34,000 because my child needed to be inpatient at Middlesex Hospital at a time when I had double insurance between Aetna and Universal Healthcare. And my family crisis was a hot potato. And each insurance company said, no, you're primary, you're primary, you're primary. I am not the only person to have these things at a time when they are in crisis. So to hear after all of the mail I've gotten from insurance and Middlesex, that this is just part of doing business is not acceptable. Do you hear me? Do any of you have kids? Do any of you have kids? Show me. These are people's lives. These are people's children. These are people's families. As a public health professional who worked at a very high level in Oregon, I can tell you other states are doing it better. Especially with Medicaid and Medicare, you can get CMS waivers. You can pay for outcomes and not for procedures. You have a person with diabetes, pay people when they don't have to take the foot for tertiary care. Pay them when they save that person's limb. Ding them when they don't. That is how you fight for your people. You think about their lives. Our governor Kitzhaber in Oregon said, you know, you have somebody who has a heart condition and it's 100 degrees, get them an air conditioner to help reduce their heart strain. Think about people's lives and what they need to survive. I also want to point out that this commission and the insurance companies treat people in Connecticut incredibly rudely. Do you understand that the people who are not paid to be here are the people that have the least amount of time and have waited the longest? You send a message, and it's very consistent across all of you. That's the rate hike.
Thank you. This one?
Next on the list is Deborah Doppler.
Good afternoon. My name is Deborah Doffney. I have a master's degree in public affairs, concentrating in healthcare administration, and I've worked in the healthcare industry for almost 2 decades. I am a resident of Connecticut who does not have access to quality, affordable healthcare. I am a small business owner who was unable to find a good option for my employees. Because today's health insurance industry works in the same manner as any other for-profit business, like, for example, a computer company. They're in the business of making high profits. One executive in an insurance company said, and I quote, "The vast majority of executive compensation is performance-based. Our leaders benefit when shareholders and a broader set of employees benefit," end quote. Performance measures are critical in healthcare and health insurance. None of these indicators addressed access to care, quality of care, or outcomes of care, because that is not why they are in business. But in a computer company, the main difference is whether or not you can get to your computer site in 3 seconds instead of 10 seconds. Whereas in health insurance, people's lives are literally at risk. While these executives and others are extremely rich, as we know, some of them making millions of dollars in salary, their members, like me, are not. If I pay $10,000 a year in premium and still have a $6,500 deductible, where do I get the money to pay for actual health care? Many of us don't actually get actual health care. We skip the doctor and live with the problem because we've already spent a huge amount of our income on our health care premium without having received any medical care. And that's what they want. That helps profits. They were asked earlier, if they could say how many or what percentage of their members did not reach their deductibles. Nobody had that answer. We talk about value-based care, which sounds great, except it's irrelevant if we can't access it because of the high deductible. Even many of the access care health plans run by a subset of the same for-profit insurance companies have $6,000 or more in deductibles. The industry has some of the highest profits in the nation, in the billions. You've heard about their millions of losses as they presented one or two segments of their business. I will summarize, thank you. You've heard about the actuarial calculations that don't include ethics or outcomes. In my small business, if I raise prices to this degree, I would lose customers. But they don't lose customers because we're a captive audience. We're scared that if we don't pay for this insurance, we won't have anything left if we have a catastrophic illness. The rate increases do not go to quality of health care to decrease deductibles or expand networks. They go to the executives to make them richer and even more richer while the poor get more poor. And then being based in Connecticut, they bully and threaten to take their businesses and jobs out of state. Please stand up to the health insurance companies and their lobbyists, to the bullying and the greed. If somebody you care about is struggling to afford their medical care and asks you who you supported in this decision, what do you want to tell them? I ask that you say no to the insurance companies and yes to the people of this state. Thank you for your consideration.
Thank you. Justin?
Next on the list is Idalise Perea.
Thank you.
I'm pulling up my testimony now. Before I begin my 3 minutes, I would like to thank the committee for allowing me to speak today and my followers on TikTok and Patreon who will be watching this later. And I'll begin. While you consider changes above the current rate of inflation, let's discuss numbers. In 2021, the same year that Anthem and Cigna teamed up with Aetna, they successfully paid lobbyists to kill a public option. Anthem and Cigna then moved to merge after a combined total of $9.5 billion in stock buybacks. Despite the higher costs mentioned for 2022 and increased utilization, Anthem paid $2.3 billion in customer premiums towards stock buybacks and $24 million in CEO pay, while Cigna paid $7.2 million in stock buybacks and their CEO $37 million. We are being asked to cover the cost of court settlements and fines that were levied on insurers in the room. These costs are for failing to pay claims in a timely manner and using algorithms to deny valid claims and more. During a time when Connecticut residents are being asked, I'm sorry, I'm nervous. Can I get that turned back real quick? During a time when Connecticut residents are being asked to tighten their belt and dip into their savings, profits and CEO compensation are at record levels. Stock buybacks, CEO pay, and lobbying are customer funded, but profits are at record levels. Profits are nothing more than money collected from their customers and not paid out in claims. Any charitable contributions by these companies are simply tax write-offs that are also customer funded. Despite evidence that pre-authorizations and the use of pharmacy benefit managers increase the cost more than hospital mergers, insurance companies continue to use PBM, and to echo doctors from the 2023 legislative session, they have to hire additional staff just to deal with pre-authorizations, and that's driving up costs. Here's what 2024 will bring if these rates are approved. Higher rates of uninsured Connecticut residents, increased costs to our state Medicaid system, wider health disparities for people of color, the working class and middle class residents, and increased medical debt. As number 5 in the country for prevention, let's look to our neighbor in the north. Massachusetts is getting a higher return on their investment at a lower cost. Connecticut lawmakers promised middle class tax relief last year and made cuts to programs used by Alice families. Let's give Alice families in Connecticut a real break. I'd also like to address the lawmaker that blames partisan politics on healthcare.
ACA was originally enacted by former Governor Romney, who was a Republican, in the state of Massachusetts. And their Medicaid program at this time takes people with higher incomes than the current Medicaid program. And I'm done. If I need questions, please. No. Thank you.
On the list is Arden Parrish.
Hi, my name is Arden and I live in New Haven. I'm the leader of the Insulin for All movement here in Connecticut. I'm coming to you today offering my own perspective, but also that of the patients and families that my organization fights for. I've been insulin dependent since I was 7 years old. That's when I was diagnosed with autoimmune type 1 diabetes. For the rest of my life, I will require a constant infusion of insulin through a pump. Without it, I would be dead in a matter of days. I'm so fortunate to have good health insurance. My plan covers most, not all, of the immense financial burden of my condition, allowing me to pay only a fraction of the more than $300 list price of every vial of insulin that I use. I have seen firsthand what happens when an insulin-dependent person loses their health insurance. 1 in 4 of us already have to ration our insulin due to the cost. Rationing increases our risk of complications and can land us in hospital, not only lowering our quality of life, but also increasing the burden on our already overworked healthcare systems. And in far too many cases, including those of Alex Smith, Jessamine Radcliffe, Micah Fisher, Jeremy Crawford, Jada Lewis, and dozens of others, rationing insulin is fatal. Insurance rate hikes kill people. It's that simple. As prices continue to increase, more and more people are forced to give up their ACA insurance. Some switch to cheaper plans that cover less of their life-saving medications and ultimately leave them vulnerable to unthinkable outcomes. Worse still, many are left completely uninsured. For people like myself, this is tantamount to a death sentence. Insurers have attributed the proposed hikes to the rising cost of prescription drugs, including, of course, insulin. But why should we, people living with lifelong disabilities who depend on these medications for daily survival, be forced to pay the price for the greed of pharmaceutical companies? Ultimately, rate hikes are not a solution to the problem of prescription drug costs. If you do truly want to keep the people of Connecticut safe and healthy, you must keep health insurance rates low and take this fight not to innocent patients like myself, but to the companies and individuals who are taking advantage of our most medically vulnerable populations. I urge you to reject these rate hikes and put people over profit. Thank you.
Thank you.
Next on the list is Liz DuPont-Gill.
Good afternoon. My name is Liz DuPont-Gill. I'm the Associate Director of the Connecticut Citizen Action Group, or CCAG. Thank you for allowing us the opportunity to testify today. We are appalled by the continuous inaccessibility of necessary care to the citizens, workers, and small businesses of the state. It is abhorrent that we have to stand here today and defend against yet another year of double-digit rate hikes proposed by insurance companies. Just 4 of these companies proposing to raise their rates for 2024: CVS Health, Cigna, Elevance Health, formerly Anthem, and United Healthcare, spent nearly $400 billion on executive compensation, profits, and stock buybacks in 2022 alone. To put that number in perspective, it is 19 times larger than the entire budget of the state of Connecticut. What these insurance behemoths didn't spend that money on was providing care for their customers. Instead, these companies claim they need the people of the state to help them maintain their services, while we know this money is actually used to subsidize the ever greater percentage of profits and enriching themselves. The already wealthy shareholders and executives of these companies have been able to afford an obscene share of health-related spending now at record levels and at the direct expense of care of thousands of our state's most vulnerable citizens. Medical issues are in fact the leading cause of bankruptcy in this country and disproportionately harm people of color. You have heard these companies repeatedly claim today that their requested rate increases are to, quote, assure the best quality care for their customers. However, we need not look far to see how denied care and services are essential to the business strategies of these enterprises. Through vertical integration, 3 of these health insurance companies in particular have been able to capitalize off the manipulative price-raising tactics of their pharmacy benefit managers, or PBMs. CVS Health, United Health, and Cigna, through their acquisitions of Caremark, Express Scripts, and Optum, have been able to monopolize the more than 80% of the market for drug price negotiations. PBMs have long contributed to the inflated price of prescription drugs. While PBMs claim to reduce prices for consumers, several lawsuits have revealed an endemic pattern of advocating higher prices in exchange for larger rebates from manufacturers, of which these companies receive a share of, and which testimony touched on here today. On the opposite end, they often use what is known as spread pricing to charge customers' health plans more for prescription drugs than they pay pharmacy forgiveness. While these middlemen have been able to reap a profit, the cost of their actions are passed along to consumers, forcing many to abandon medications critical to their health. And I'm going to pause my testimony in respect for time. My colleague Colin was, is going to continue some of CCAG's testimony. But I would say that some of this research and others is all available at ccag.net for people who want to learn more about the practices of the industry, whose driving motive is not to provide care for people, but to enrich shareholders. Thank you.
Thank you. Following you will continue the testimony.
Hello. In continuation of the discussion on PBMs. Now that these companies own the PBMs negotiating prices of drugs on their plans, and all at pharmacies they ostensibly own as well, these companies have made more money than they ever have before without a hint of transparency. Here's what we have found. In 2022, CVS Health's PBM Caremark was its most profitable division, bringing in over $7.8 billion, more than either Aetna's health plan or the company's 10,000 retail stores. Additionally, Cigna's Express Scripts now generates more in profits and revenues than its health plans. Since 2013, revenues from United Health's PBM have soared almost 530%, capturing $27.8 billion in revenue in just the first quarter of 2023, as access to prescription drugs on their plans has become ever more limited. In 2022, the amount of revenue these 3 companies reported to derive from the PBMs alone was close to $500 billion at $492.3 billion, or 60% of their total revenue. And because PBM spending counts towards their medical loss ratio threshold under the Affordable Care Act, they can use the PBMs they now own to corruptly circumvent the consumer-focused intent of this law, meeting their federal obligations by paying themselves instead. It is no wonder the FTC has initiated a formal investigation into these practices nationwide. The ownership of PBMs by the health insurance companies they negotiate on behalf of has only amplified the manipulative drug pricing schemes of this industry. As for rising medical costs, these insurers are very intimately aware of this phenomenon, having consolidated with many of the medical providers contributing to this increase. Additionally, while hospital costs have risen on a scale around 2% a year, from 2021 to 2022, stock buybacks increased by almost 50% and CEO compensation by 18% for the companies here today. These insurance companies have built their empires on the backs of this country's workers, citizens, and small businesses. When they want to cut costs, they don't shrink executive compensation or stock buybacks. They predatorily overcharge people for prescription drugs they need to survive. They systematically deny claims without even reviewing them, as Cigna has been caught doing again just this past month. They lay off their workforce en masse, as CVS Health is currently doing with over 500 workers at Aetna's Hartford branch. And they raise customer premiums just as they are trying to do today. This will never end. We say enough is enough. The Connecticut Insurance Department must deny these rate requests and choose the care of its citizens over the maximization of this industry's profits. Thank you.
Thank you.
That concludes our list of our list of public comments.
Thank you all for sharing your insights and perspectives during today's informational hearing, but let me just verify before I end. Justin and can you verify that we've got to everybody on the list? Moving forward.
Everyone outside of Senator Brooks.
Thank you. Senator, are you?
She is not.
She is not, thank you. Then seeing no other speakers, we will now conclude this information. I'd like to extend my gratitude to each of you for taking time from your busy schedule to participate here today. I know this was not always easy, but thank you for sharing. Everybody who was here, thank you for taking the time to do this. Your insight, your inputs are greatly appreciated. Thank you. I now close this.